We are live.
Hi, good evening,
Good
everybody.
evening. Good evening, everyone. Welcome to the AIOS ARC program. On behalf of our team ARC and our chairman, Dr. Prashant Bhawankule, we welcome all of you for the subspecialty CME program. So we have concepted the subspecialty CME program. It started in the month of January. We are now associating, ARC is associating with various subspecialty societies of India. In the Jan, we started with Pediatric Ophthalmic Society of India, and in the Feb, we had associated with Vitreoretina Society of India. And March was the AIOS, annual AIOS. So in the April, we are now associating with the Neuro Ophthalmic Society of India. So this subspecialty CMEs is basically aiming at the comprehensive ophthalmologist. So we have galaxy of speakers here today in the field of neuro-ophthalmology who is going to teach each and every one of us simple things about how to take up in day-to-day practice. Beautiful take-home messages are very, very important for our comprehensive ophthalmologists so that they can implement it in their practice from time to time. So with this welcome note, I would like to welcome all the speakers and the expert panel, Dr. Ambika, Dr. Shikha Basi, Dr. Virendra Sachdeva, Dr. Mahesh Kumar, Dr. Jyoti Matalia, Dr. Raman, and Dr. Jasprit Sukhija, with various speakers who are here today. And we have two star moderators who will be moderating this whole session. We have Dr. Reshmin Gandhi, and then Dr. Rohit Saxena will be taking it forward from here on. So I wish the program all the success. Will be here with you and to learn more and more in the field of neuro-ophthalmology. Over to Dr. Rashmin, please. Thank you.
Thank you, Dr. Srinivas. And first of all, on behalf of all the panelists, speakers, and the audience, I would like to thank the ARC for partnering with INOS, the Indian Neuro Ophthalmology Society, for this program. I have with me Dr. Shikha Basi, who is the Deputy Director of Neuro Ophthalmology from Shankar Netralaya, and she will be moderating the session. I hand over to you, Shikha, for opening remarks, and then we'll go to Digvijay as the first talk. Shikha.
Good evening, everyone. Thank you, ARC. Thank you, Dr. Rashmin Gandhi, for giving me this opportunity to moderate this beautiful webinar. And with that, I think without wasting any time, I invite Dr. Digvijay to give his talk on how do I check if the optic nerve is functioning.
Thank you. And yes, indeed, it's a pleasure. Thank you, Dr. Shikha, for that introduction. Let me put this on PowerPoint. Yeah, is that visible?
All good, doctor.
Yes.
All right. Right. So, this is for the general ophthalmologist. So some of this may appear simple, but these are the important parameters. And as a neuro ophthalmologist, we have to know, how do I check if my optic nerve is functioning normally or not? So on the optic nerve, there are structural parameters, which is basically how the optic nerve looks to us in terms of how's the size, the shape, the margins, the color. Remember, the color is an important thing in neuro ophthalmology that we look forward to looking at evaluating. And then we also have the structural aspects to look, which could be investigated through the optical coherence tomography. On the other hand, we have the functional aspects of what the optic nerve does. And here we're looking at the visual acuity, the fields, the color vision, the contrast sensitivity. And then you've got indirect measures of seeing how the optic nerve is functioning, like the pupillary reactions that are there. Or you can look at stereo acuity, of course, which is a little far-fetched method, but it does tell us about how the nerve is functioning overall. And then we have electrophysiology, which is going to basically be able to look at it from a non-clinical but an electrophysiological standpoint. And we have the visual evoked response under that heading. And of course, there are other electrophysiological tests too, but we'll stick to VER, for this webinar at the moment. In terms of history, we look at take history of a visual dysfunction. Since when? Is it getting worse? Is it improving? Are there any associated factors? Is it acute, chronic? So these are kind of the typical history that we would take for any neuro-ophthalmology case. And based on the course and based on whether there are any other associations, we try to make diagnosis. For the optic nerve specifically, we look at since when is how rapidly the particular visual dysfunction happened and try to classify it into vascular causes or all the way into chronic, where we have compressive causes like space occupying lesions. So this chart kind of helps us come to a conclusion. But let's look at the examination and let's look at the structural examination of the optic nerve first. So in the fundus, we always prefer to do a dilated fundus examination. But remember, Do look at your pupillary reactions before that. We get a lot of cases where the pupillary reactions have been missed out and they carry the answer to whether the optic nerve is working well or not. You can do it through a slit lamp biomicroscopy, through a direct ophthalmoscope. We normally prefer the stereoscopic methods like the slit lamp, and definitely do an indirect ophthalmoscopy. Look at the rest of the retina. Optic nerves are often associated with other problems in the retina as well. On the disc, look at the size of the disc. Typically, we know that the disc diameter is somewhere in the range of about 1.8, 1.9 millimeters, slightly. The disc is always slightly oval in shape, but typically the size is important because small discs could be could be a sign of hypoplastic discs or hypoplasia of the disc. Similarly, a large disc could be a megalopapilla. Again, and these could have functional aspects to them. The shape is not so important, generally, and it doesn't have an association directly with visual dysfunction. But yes, abnormal looking discs, colobomatous discs, yes, they will have visual dysfunction. In terms of the color, like I said, it's important. Normally, it's salmon pink in color. If it's pale, then you're looking at atrophy. Some kind of a visual dysfunction is likely to be there. If it's too hyperemic, it could be papillitis or a neuritis or some sort of an inflammatory neuropathy that you're seeing. The neuroretinal rim around the disc, the margins of that tell us, is the disc edematous or not, as well as how the retinal nerve fiber along that will look. And the cup disc ratio, while not so important for neuro-ophthalmology, more for glaucoma, also in some cases of neuro-ophthalmology, you may see an excavation in the disc that could be there. Disc vascularity is an important sign. So if you're getting less than 6 vessels on the disc, that's likely to be atrophic. More than 10 or 10 or more is normal. This is called the Kestenbaum sign. You should be familiar with this. Look at the peripapilla. Look at the retinal nerve fiber around the disc. Do you see defects? Do you see edema in all those areas? Do you see any changes, hemorrhages? And let's look at a few pictures now. The disc, this is a normal looking disc in the top picture there. Below, you're seeing a hyperemic disc, slightly blurred margins. This is a papillitis case. You could get temporal pallors in the discs, as you see in the top image, which could be in toxic or nutritional deficient neuropathies. Inflammatory neuropathies will have like a hemorrhage, a little angry looking disc, hyperemic looking discs. And you could have pale discs over time, which are ischemic. It could be sectoral. You can see sectoral edema in this. You can see a sectoral pallor that may be there. And then sometimes you'll get these kind of fibers around the disc called the myelinated nerve fibers. They may have no functional significance at all, and you should be aware of them. Neuroretinitis, see, it's important to look at the macula and the rest of the fundus. You can see here exudates at the macula. And in severe disc edema, like in papilledema below, you can see the discs are edematous, very swollen, hemorrhages, tortuous vessels. You cannot make out the contours. The cup is obscured. So all these are signs that the disc optic nerve probably is not functioning normally. In terms of a pale disc, now we come to atrophy. It could be a primary optic atrophy where you get a well-defined waxy, a well-defined yellow-looking disc. Margins are good. You can make out the contours. You can look for the cup and a very, white-looking disc. On the other hand, you may get one which is looking gray, dirty margins, feathery. You cannot make out the contours, looks elevated. This is a secondary optic atrophy. The one on top, primary optic atrophy, usually would happen when there's been no disc swelling before the optic atrophy, while the secondary generally happens associated with a disc swelling in the past. The OCT can help confirm edema, as you can see in the images here, as well as it can look at the retinal nerve fiber layer. It can tell you whether there's an edema in that or whether there is any kind of a thinning, which is seen in atrophy, as you see in the picture on the bottom right. Now let's come to the functional aspect. Probably this is the most important part of it. Visual acuity, remember, it's an important baseline parameter, but may many times be normal in a lot of neuro-ophthalmic conditions. Your optic nerve may have dysfunction, yet your visual acuity is okay. It's important to do this. The Snellen acuity usually does the trick, but allow the patient some time to see. Always look for best corrected acuity or pinhole acuity, and that does play an important role. Near vision also is important to note. Color vision is so optic nerve diseases generally would affect color vision in a lot of the cases, and this is more so with neuritis, optic neuritis, papillitis, retrobulbar neuritis, where there's a red desaturation and the red color gets affected. Before, so remember, red-green color deficiency is more likely to be seen in optic nerve disorders, blue-yellow more in macula. But you can do formal testing methods like the Ishihara charting that you see here, because color vision, I think, is a very, very important parameter as a neuro-ophthalmologist to know about optic nerve function. But remember, it may be normal in a lot of cases of papilledema, and all color vision may not be affected. Contrast sensitivity, again, is a sensitive parameter seen in a lot of studies, which is basically, sometimes it may happen before the visual acuity loss actually. And again, it's something that can be tested formally and is a sign of optic nerve dysfunction. Visual fields are important. It's telling us about the field around us, and this can be tested. Gross visual field defects in neuro-ophthalmology can easily be picked up on confrontation fields, which can be done in the method shown above on the slide. But then you have formal field testing methods like the static perimetry, or you've got the Goldman kinetic perimeter that you can see the images on the right, which can again pick up optic nerve conditions. Remember, optic nerve field conditions are generally absolute scotomas, and they follow the vertical meridian in a lot of cases. But you can have central scotomas, as you see in the Goldman kinetic perimeter images that you see on the right of the screen here. And the same central scotomas are seen on the Humphreys visual field below. Fields may also be constricted, as you see in the central Humphrey visual field here. And so you need to know all sorts of field defects can happen with optic nerve dysfunction, but constrictions, central scotomas are, are specific to these cases. Like I said, the pupillary reactions are important. They're indirect sign of optic nerve dysfunction. You should know how to do the swinging flashlight test, whereby you ask the patient to see in the far distance and you swing a flashlight rapidly from one eye to the other, and you look at the pupillary reactions. So let's see what's happening here. On the image on top, you can see this is the normal pupillary reaction. You've got the pupils looking far, slightly dilated. You put a flashlight on one eye, it constricts. You shift the flashlight to the other eye, it still remains constricted. But if there is a relative afferent pupillary defect, as you see in the image below, it is constricting when the right eye is seeing a torch, but when the left eye is being shown the torch, you can see it's dilating. So both the direct and the consensual reflex in the other eye is showing a dilation of the pupil. So this is a left RAPD. And I'll just demonstrate this on this video. You can see we've shined a light on the right eye. You could see that the left eye was not constricted. Now, when we come back to the left eye, you will see that it constricts very well the pupil. But as soon as we go back to the right eye, it is again dilating. So this is a right RAPD. And so this is a sign that there is a right optic nerve dysfunction. It's a very specific sign, and this is a sign one should not miss. Another indirect sign, which I think, well, is something that we don't routinely do, could be stereoacuity. And we sometimes do this to rule out malingering and other issues. But there are other causes which may affect the stereoacuity. So it's something that, is just like an additional test for us. Electrophysiology, again, very important, because this is where we can objectively look at the parameters without the patient really having to consent to see very well. The visual evoked response could be a flash, where you give a flash stimulus in this Nicolan glands filled drum that you see below in the picture, or it could be a pattern, checkered board pattern, where the patient is looking straight ahead. You will get a graph which looks like this. On this, there will be an amplitude of the lowest to the highest point here, as well as certain latencies of the P100 wave, which is this wave here. So normally the amplitude is in the range of about 8 to 10 microvolts, and the latency is about 80 to 100 milliseconds. So any latency going beyond that, or an amplitude which is getting lower, is a sign of optic nerve dysfunction. As you see on this image on the right side, you can see that the left eye is showing a flat graph. So there has been non-recordable VEP here, but the other eye is showing a good graph. So again, VEP can be used even in cases where patient is not cooperative, non-verbal, even in unconscious patients or in even very little children, we can do this, and it tells us a lot about the visual pathway dysfunction, not necessarily the visual optic nerve alone. So that again, you need to recognize. So the take-home message is that yes, when you are going to look for, is my optic disc functioning normally, look at the structure of the disc. That gives you a hint that is it likely to be functioning normally. Look at the function of the disc, put those two things together and create your diagnosis, your decision. But do remember, the structure may be completely normal and still your optic nerve could have dysfunction. Your functions, a lot of the visual functions may be completely normal. So it's important to test a plethora of them to be able to actually pick up a dysfunctioning optic nerve. Thank you for your attention.
Very nice presentation, Dr. Digvijay. When one wants to know whether the optic nerve is functioning, either if the fundus is normal or if one needs to confirm whether the papilledema or the optic disc swelling one is seeing is true or not. So my question to the panel is like, how does one confirm in case of a normal fundus if the vision loss is because of a maculopathy or because of the optic nerve dysfunction?
So can I take on that?
Yeah, please, Dr.
Jasprit, go ahead.
Yeah. So I think it's a very well summarized what Digvijay has said, and it's always a clinical and objective parameters what you have to see before actually knowing what it is. But yes, sometimes you do get confused whether in subtle maculopathies or maybe subtle optic nerve defects. So one important thing is a photostress test. That's very important. So in photostress test, if you have a macular problem, you're going to have a prolonged after image time because of the bleaching of the pigments. Whereas in optic neuropathy, that won't happen. So that is one important thing which you should test when you're confused between whether it's the retinal issues or the optic nerve issues. The other thing is sometimes you get confused whether it's like the patient comes after maybe a number of years, he's coming and presenting and says, I had some loss of vision. You're confused whether it was a amblyopic eye or has he got an optic nerve problem. So there comes the role of a neutral density filter. The moment you put it, and if he has an optic nerve problem, the vision would drastically go down. Whereas if it's amblyopic, probably it would be just a mild deterioration of visual acuity. The other things is very well covered. Red-green color blindness, specifically if you have to test, it's blue-yellow in the retinal issues, red-green in the optic nerve disorders. So those are things which probably one should look at, because the confusion lies between subtle maculopathy and subtle optic nerve disorder. Otherwise, if you have frank optic neuropathy with a decreased vision, with a pupillary involvement, with the contrast sensitivity decrease, probably it is an optic neuropathy. So that's just why I wanted to add.
One more point I would like to make, and he has very beautifully spoken, is about the pupil involvement. So if you're able to show a relative afferent pupillary defect, it's pathognomic that that particular eye has a optic neuropathy, because you would not get an RAPD if there's anything else, only in an optic neuropathy. And that is important, especially if you have a normal nerve. So the confusion comes when the optic nerve is perfectly okay, in which case we are looking at something called a retrobulbar neuritis, which is common for a demyelinating. So if you have a normal disc, and therefore it's very important that a pupil examination is something all general ophthalmologists should master, because if you're able to pick that up, we know it's a unilateral. Also, one thing is there that if you've picked up unilateral optic neuropathy, but after a couple of weeks, the patient comes back and you see the pupillary reflex has now become sluggish, then you have to carefully look at the other eye. Because in case you have a bilateral optic nerve involvement, you will never have an RAPD. So there is no concept like bilateral RAPD. It's basically both eyes become sluggish. So this is what you need to know. So the basic bottom line is learn to have a good pupillary examination so you are able to pick up a relative afferent defect.
Superb. Thank you, Jyoti. I think that sets up beautifully for a talk by Dr. Madhavi, because we have a talk on pupil, and I'm sure she'll be covering all these aspects even but in more detail. Over to you, Shikha, for the next talk. Thank you, Jyoti.
Yeah, with that, I invite Dr. Rohan, who will be talking about the visual field effects in neuro-ophthalmology. Dr. Rohan is a consultant. He's a neuro-ophthalmologist at LB Prasad Eye Institute, Hyderabad. So over to you, Dr. Rohan Nalwani.
Thank you, Dr. Shikabasi, and good evening, everyone. Are my slides visible?
Yeah.
Okay. So I want to thank the ARC, AIS, Dr. Baban Kule for this opportunity. And I will be talking on interpretations of visual fields in neuro-ophthalmology. So this is the outline of my presentation. So I will be talking on the neuroanatomy and the visual field effects. I will take you through the 7 steps of interpreting visual fields. A few cases I will be discussing, and I will be concluding, and I will leave you with food for thought. Visual field effect indicate the involvement of the visual pathway, and the patterns of the visual field help in localizing the site of the lesion. So it helps in diagnosing the patient. So visual field also help you in monitoring and the resolution and the recurrence of the disease, and helps us in follow-up. Now, since visual field effect adversely affect the patient's ability to it affects the day-to-day ability, such as reading and driving, this field effect should be actively sought after while considering the rehabilitation strategies. So coming to the neuroanatomy and the visual fields, the optic pathway begins in the retina, which is the complex structure made up of 10 different layers. It consists of 2 different types. It has a nasal retina. It has a nasal nasal retina, and it has a temporal type. Now, the nasal retina will control the temporal part of the retina, while the nasal field field will be controlled by the temporal retina. Both of them join at the optic nerve, and they are directed posteriorly to form the optic nerve. They travel to the optic canal, and they exit through the middle cranial fossa, and they join each other at the optic chiasma in the middle cranial fossa. Now, at the optic chiasma, the nasal part of the retina of either of the eyes will decussate, which means that in the right eye, the nasal retina of the right eye will decussate and will join the temporal fibers of the left eye and at the optic chiasma. From the optic chiasma, there is the optic tract, and optic tract, the axon synapses at the lateral geniculate body. From the lateral geniculate body, there are two fibers, which is the superior fibers and the inferior fibers. The superior fibers will pass through the parietal lobe and terminate at the occipital lobe, which is the primary visual cortex. The Myers loop will travel through the temporal lobe and will terminate at the occipital fibers. So this point of time, I just want you to remember the three visual field effects. The first one is, let's assume that there is an injury at the optic nerve, which means that the nasal part of the retina and the temporal part of the retina is involved, and so the of the optic nerve is involved. So for what field effect we'll get? There will be decrease of vision in the left eye, and this is the visual field that we will get. Let's come to the if there is an injury to the chiasm, which means that the nasal part of the retina, nasal fibers of the optic nerves are getting involved, which means the temporal field will be involved, and you will get the bitemporal hemianopia. So as you go posteriorly, it's going to be more of a homonymous hemianopia, which means that from the left side, the temporal fibers will be involved, and from the right eye, there will be nasal fibers will be involved, which will give you right-sided homonymous hemianopia. The details of other field effects we will be covering in the subsequent slides. So the rules of interpreting visual fields are, let us follow a few rules. Interpret visual fields of the both eyes together and keep eye prints of as the patient sees. So let's keep printout of the left eye to your left side and the right eye to your right side. So let's move to the step one. The first step is to determine whether the fields are reliable or not. If the fields are unreliable, it may give rise to a very fallacious pattern, which on repeated testing will determine actual field effect. So therefore, make sure the fields are reliable or not. Now, once you confirm the fields are reliable, look at the field effect. It will appear as the central depressed point, as in the central scotomas in this particular patient, and inferior field effect, inferior altitudinal or inferior arcuate field effect in this particular patient. The step 3 is to determine whether the field effect is in one eye or both eyes. Now, if the field effect is in one eye, it is likely to be the retinal or optic nerve pathology. So in this case, there was a old retinal detachment, and which is inferior and causing the superior field effect, as we can see here. The next step is if the field effect is in both eyes, whether the field effect is respecting the vertical midline or the horizontal midline. Now, if the field effect is respecting the vertical midline, it's going to be a neurological field. So the lesion is going to be either in the chiasma or retrochiasmal lesion. The next step is if it's vertical, if it's following the vertical, respecting the vertical midline. So it's important that you determine whether it's a bitemporal hemianopia or homonymous hemianopia. Now, bitemporal hemianopia is due to the damage to the nasal fibers of optic chiasma, and it could be due to the damage to the cella, which is due to the cella tumors. On the contrary, if it's a homonymous hemianopia, it suggests that the retrochiasmal pathway, that is the optic tract, optic radiation, or occipital lobe, could be damaged. So how to distinguish it further? So the next step is to check for the completeness of the hemianopia. If the field effect is complete, so there is no further localizing value. On the contrary, if the field is incomplete, check whether it's incongruous or congruous. Congruous means the field effects are the mirror images, and incongruous field effect means the lesion is likely to be the anterior retrochiasmal pathway, which is the optic tract or lateral geniculate body. So how to go ahead further? How to distinguish in the intervening areas such as the optic tract, or optic radiations and occipital lobe. So you have to look for other features. So in case of optic tract lesions, you are going to get incongruous field effects. For example, in optic tract lesions, there could be contralateral RAPD and asymmetric optic atrophy. And that can be attributed to the 53% of the fibers coming from the nasal retina to the contralateral optic tract. Moving ahead to the optic radiations, we have a superior fibers and the inferior fibers. Now, the superior fiber, if they are damaged, you are getting to you will get the field effect which is inferior, and that is classically called as pie on the floor. And vice versa, if the inferior fibers are involved, you will get the field effect which is superior, which is called pie in the sky. As you go more posterior in the occipital lobe, the field effect, as all the fibers terminate in the occipital lobe, which is the primary visual cortex, all the field effects are going to be more of a congruous and macular sparing. So let us see what we have learned until now. So this is a case which was referred to the Neuro Ophthalmology clinic, and this patient had occipital infarct. So the left side of the field is front of the left eye, and the right side of the field is in front of the right eye. And the fields are fairly reliable, has field defects on both eyes, has both the fields are respecting the vertical midline, and you have homonymous hemianopias, right-sided homonymous hemianopia. But if you look closely, there is a field defect which is in the right eye, which is inferior as well. So let us see the optic disc. So the left eye optic disc is fairly normal, 0.4, 0.5 cup, while in the right eye there is a superior rim thinning, and that can be so that can correlate with the inferior visual field defect in the right eye. So it's very important that you correlate your disc findings, your imaging findings with the visual fields. Again, one more case where the left eye had the temporal field loss, and the right eye on the grayscale you have a superior temporal depression. So this is a classical junctional scotoma where the pituitary tumor is being partially compressing the optic chiasma. And if you just go back here, if the superior temporal field defect is likely to be due to the injury of the Willebrand's knee. One more point that I want to add here is many times the 30-2 visual field may miss the early junctional scotoma. In those cases, you can have a broader visual fields. So to summarize, we have 7 steps, which is the field reliable? Is there a field defect? If the field defect is in one eye or both eyes, if it's in both eyes, whether it is following the vertical or horizontal meridian, if it's vertical meridian, if it's homonymous or bitemporal. If it's homonymous, is it complete, incomplete, congruous, or incongruous? And what are the added features such as RAPD or asymmetric optic atrophy? And more importantly, always have a good clinical evaluation and correlate your visual fields with your fundus and optic disc findings, and then correlate with the MRI findings. I will leave you with the food for thought: which retrochiasmal pathway lesion will cause monocular field defect? These are my references. Thank you.
Thank you. Thank you so much, Dr. Rohan, for that wonderful talk on visual fields. And the success of these programs is mainly because of the wonderful speakers and the discussion that is generated by the renowned expert panel. And we are really fortunate to have the expert panel who has joined us, and I'll be introducing them as they come and participate. We heard from Dr. Jasprit Sukhija, who is joining us from PGI Chandigarh, and Dr. Jyoti Matalia, who joined us from Narayan Netralaya, Bangalore. Can I now request Dr. Mahesh Kumar to give his expert comment on visual fields? Mahesh joins us from Arvind Eye Hospital, Madurai. Mahesh, are you here?
Yes, thank you, Dr. Ashwin. So it was a wonderful talk by Dr. Rohan, and yes, beautifully demonstrated that visual field is one of the most important investigations in the armamentarium of the general ophthalmologist as well as the neuro ophthalmologist. So he has brought out all the points, including the optic tract lesions where RAPD is an important finding. One more point I would like to add there is these patients will have a bow tie atrophy. In the optic tract lesions because of the arrangement of the nerve fibers. So another point I would like to add is, in general, as opposed to glaucomatous field defects, in general, these are all qualitative field defects. In neuro-ophthalmology, it's either all or none phenomenon. However, there are 2 or 3 conditions in neuro-ophthalmology where we would like to quantitate, like glaucoma, for example. We serially follow the idiopathic intraocular hypertension patients with by means of visual fields, and any change in the quantitation decrease, we would like to intervene. Next is a thyroid orbitopathy, which causes an optic neuropathy.
Sorry, I can't help with that.
Can also cause this. So these are all some of the specific points which we would like to point out in case of neurological field defects. That's it, Rashmi.
Thank you.
Rashmi, I want to add one more thing. So before we start on Amplis visual field perimetry, So every case, I think in the clinical bedside or in the OPD is better whenever there is a visual dysfunction or any field defect is suspected, like in all neuro-ophthalmic diseases. It is a better to do first confrontation visual field as a clinician, and then we can go on to do the automated field perimetry. And it is a
Thank you.
very good presentation by Rohan.
Yeah. Thank you, sir. Thank you. That was Dr. Raman. Dr. Raman is a director of the Pediatric Ophthalmology and Strabismus at the famous Sarojini Eye Hospital in Hyderabad. Thank you, Dr. Raman, and thank you for joining us.
Thank you.
Yeah, so let's move on to our next talk, and may I now invite Dr. Varna Shah. Dr. Varna is joining us from Arvind Eye Hospital, Coimbatore. Varna, can you share your screen, please?
Yes.
Varna is going to talk to us about the sixth nerve palsy. What will she do next if she see a patient with sixth nerve palsy? Over to you.
So good evening, everyone. At the onset, I would like to thank Dr. Prashant Bavankule and Dr. Rashman Gandhi for giving me the opportunity to speak today on sixth nerve palsy. What next? So we all know that the sixth nerve controls the lateral rectus muscle, which abducts the eye. So in a study done in our hospital, the sixth nerve palsy was the commonest occurring in adults, and this result resonates with other studies in India as well. The possible etiology and the probable site of lesion has to be determined to manage these cases efficiently. So acute, chronic, sudden, gradual, now all this may seem confusing, but it's not complicated at all. You just need to follow a systematic approach. So let me try to make it simple by going through a few cases. My first case is a 66-year-old woman who presented with a sudden onset, double vision, binocular, more in the left gaze since 4 days. She was a known diabetic and her sugars were not well controlled. Examination revealed a 15-degree esotropia of the left eye with abduction restriction. There was no papilledema, moderate NPDR was seen in both eyes, and other cranial nerves and neurological examination were grossly normal. So a quick recap, clinically, a sixth nerve palsy can have a face turn towards the action of the affected muscle. Why? To avoid diplopia. Esotropia due to the unopposed action of the antagonist medial rectus muscle. Binocular diplopia with horizontal separation of images, and this will be an uncrossed diplopia. And finally, a limited abduction. So back to the case. Her routine labs were normal other than an increased RBS and HbA1c of 8.4%. So she was diagnosed as an acute, isolated, vasculopathic left sixth nerve palsy. We followed a conservative approach, advised temporary occlusion of one eye, methylcobalamin tablets, and good glycemic index control. So diplopia was reduced after 2 weeks, and after a month and a half, she was asymptomatic. Now, in other parts of the world, neuroimaging would have probably been advised at the first visit. But in our setup, due to financial constraints, we wait. However, we usually explain that if there's any new or worsening of symptoms, an immediate follow-up is warranted. Now, my second case, here again, an elderly woman with diplopia, high blood sugars, but additionally, she had a severe headache and an elevated ESR with restricted abduction. So MRI, MR angiography, brain orbit contrast was advised, and this was suggestive of a skull-based osteomyelitis with multiple mycotic pseudoaneurysms. She was immediately referred to a neurologist, but unfortunately, she passed away due to the rupture of the aneurysm and hemorrhagic stroke. Similarly, we all have seen cases during the COVID pandemic where fungal sinusitis presented as an acute, painful, isolated, or multiple cranial nerve palsies. So the point to remember here is that though ischemia is the commonest etiology for an isolated sixth nerve palsy, in certain cases, urgent neuroimaging and referral is warranted not only to preserve vision, but also in order to save the life of the patient. Now, switching gears a little bit now, let's go along the course of the sixth nerve. Lesions of the nucleus are unique as damage to the nucleus results in a horizontal gaze palsy as the abducing nerve innervates the ipsilateral lateral rectus and the internuclear neurons cross the midline to the contralateral MLF to innervate the medial rectus on that side. So this was a 47-year-old male who presented with sudden diplopia. He had a right abduction restriction, no lag ophthalmos, corneal sensation was normal, no papilledema. His MRI showed multiple cavernomas in the brain and pons, and a typical popcorn appearance was seen. So here the neurologist followed a conservative approach, and we also managed by occlusion of one eye. Now prisms are an option here, but the patient wasn't very comfortable with them. Lesions at the fascicular site usually have fellow travelers, meaning neurological associations. For example, in foveal syndrome, apart from 6, you'll have 7th, 8th, ipsilateral Horner's. In Millard-Gubler, ipsilateral 6, 7th, contralateral hemiplegia. So the take-home message here is that a neuro-ophthalmic examination should begin as soon as the patient enters your cubicle. You need to observe if the patient has a particular gait or weakness of limbs or hemiparesis, face turn, deviation of angle of mouth. And last but not least, other cranial nerves need to be checked. A special mention about the 7th nerve as it is very close and goes around the 6th nucleus. Now, at the subarachnoid space, the 6th nerve palsy is it's usually a false localizing sign occurring due to raised intracranial pressure due to IIHT or CVT or tumors. So please look for papilledema. So this was a 53-year-old female who presented with headache. She had abduction restriction in the right eye, bilateral disc edema or papilledema. Her right 5th, 7th, and 8th nerves were also affected. Neuroimaging revealed a large skull-based mass, which was suggestive of a glomus jugular tumor, and she was then referred to neurosurgery. Now, petrous apex syndromes also occur at the subarachnoid site. So, Gradinego syndrome is characterized by trigeminal facial pain. 6th, 7th, and 8th nerves are involved. As shown here, automastoiditis, skull-based osteomyelitis, and in this case, the inflammation extended to the right cavernous sinus. So this can occur following a complicated otitis media and is seen in children with frequent ear infections. Nowadays, the 6th nerve is known as the tumor nerve. Cerebropontine masses like trigeminal neurofibroma, acoustic schwannoma, etc. All this emphasizing again the importance of checking corneal sensation and hearing. Craniopharyngeal carcinomas, clival meningiomas may all present to us first with a 6th nerve palsy. And to drive home my point of tumor nerve even further, this was a 56-year-old woman who presented to us with chronic, progressive, gradual binocular diplopia of a month's duration. She was not a known diabetic or hypertensive. However, she was a thyroid disease on homeopathic treatment since 5 years. She had left abduction restricted, left corneal sensation reduced. She had noticed a change in her voice and had a non-tender enlargement of the thyroid gland. Her MRIs showed a large mass in the petrous apex and thyromegaly with multiple nodules with central necrosis, which was suggestive of malignancy. So this was a 6th nerve palsy due to the metastasis of a thyroid carcinoma. So she was referred later to an oncologist for biopsy and further management. Now coming to the cavernous sinus syndrome, the patient usually has periorbital or hemicranial pain, usually associated with other cranial nerve palsies. Proptosis may or may not be present. Lesions in the orbit like inflammatory pseudotumors also present similarly. Traumatic 6th nerve palsies are not common. It usually occurs after severe blunt end trauma, like showing a temporal SDH here. Petrous bone fractures, where basal skull fractures, you have to look for other nerve involvement, battle sign, etc. This was a young man who presented with diplopia after a road traffic accident. He had enophthalmos, abduction restricted. His post-duction test was negative. CT brain and orbit showed multiple fractures. So he was advised occlusion, and after a month, there was complete resolution of the 6th nerve palsy. So if we see patients with proptosis, chemosis, ophthalmoplegia, please keep CCF in mind. A dilated superior ophthalmic vein can be elicited by doing an ultrasound in the OPD. However, MRA or digital subtraction angiographies are investigation modalities of choice. And the intervention radiologist usually manages these by endovascular coil embolization, as seen in this rare case of pseudoaneurysm of the intracavernous part of the internal carotid artery and CCF, where after embolization, the extraocular movements returned to normal and there was a resolution of the dilated episcleral vessels. This table summarizes the etiology and the sites. I'm not getting into this for want of time. Now coming to the treatment options, the initial management is usually with occlusions or prisms if stable. Late management, elderly or patients who are ill, again occlusion, prism therapy for small angles, Botox injection for intermediate, and surgery for intermediate or large angles. Surgery is usually done after 6 months, a recess-resect procedure of the horizontal muscles, and the transposition procedure with or without Botox into the ipsilateral medial rectus. Now, other causes of abduction weakness are to be kept in mind. They are thyroid eye disease, myasthenia, myositis, medial rectus entrapment after trauma, and in Duane's retraction syndrome type 1, as we all know, apart from abduction restriction, you get a narrowing of the palpebral aperture on adduction. And my last case is a 29-year-old male with diplopia. To our astonishment, the MRI was suggestive of a thickened medial rectus. Bone marrow biopsy confirmed an acute lymphoblastic leukemia. So this was a case of esotropia due to medial rectus infiltration mimicking a left sixth nerve paresis. So keep in mind that diplopia can be the only presenting symptom of ALL, and it can involve either an extraocular muscle or a cranial nerve. So to conclude, an easy algorithm that can be followed in our day-to-day practice. Below 60 years, whether acute, chronic, isolated or multiple with vasculopathic risk factors or not, neuroimaging is a must at the first visit. Over 60 years, if it's acute, isolated, no history of carcinoma with vasculopathic risk factors, non-progressive, we can follow a conservative approach, follow up at regular intervals, and then if there's no improvement, image. Since etiology is very important in neuro-ophthalmology, if no cause is found, consider alternative diagnosis, repeat or perform tests, follow up at regular intervals, reassess if there's progression or new manifestations, or if there's no progression or no improvement after 3 months. And I would like to end by saying that please just don't write MRI brain on the requisition slip. The type of imaging depends on your clinical diagnosis. So MRI brain plus orbit to rule out nuclear lesions or whatever etiology you suspect. So add contrast for inflammation or infections or tumors, MRA for aneurysms, MRV in cases of papilledema. This helps the radiologist know what you clinically suspect, and this makes your management more complete. Thank you.
Great talk, Dr. Varna. Really very informative. And with that, I invite comments from Dr. Ambika and Dr. Raman.
Madam, yeah, one thing, it's a wonderful talk and a very beautiful collection of cases actually. But a small suggestion from my side is, it is not 60 years, madam. I think we can consider 50 years as better, as per the new,
Yes.
the literature. And one thing, second thing is, whenever there is a multiple cranial palsies, irrespective of any age, so it's a must to do an opt neuroimaging with proper clinical localization. We should speak to the radiologist, whomever we are referring for the neuroimaging. And the neuroimaging modality must be the MRI brain with contrast and with the area of our interest. Depending on our the clinical presentation. So that is most important. Until unless there is a contraindication for contrast enhancement, I think contrast has to be used, and we should discuss with the radiologist. That is.
Dr. Ambika?
Dr. Verna, and I think we say that they have age no bar for sixth nerve, because sixth nerve, as Verna has rightly told, is a tumor nerve. And watching a patient with sixth nerve, unless I'm going to be very sure that he's going to come for a periodic follow-up, I may not shoo him away without an imaging. So if you see a sixth nerve and you're not sure that it is not going to come back for follow-up, always ask for imaging, because the indexes of we having a positive finding on a sixth nerve with intracranial lesion is quite high. And as she has rightly pointed, we need MRI brain and orbit to not miss the orbital apex or a superior orbital fissure lesion that's very common to present with isolated sixth nerve palsy with tape. So that you have to be very careful when you're asking for an imaging. And another important factor, which probably I don't know whether I looked at in the presentation, if you see a cranial nerve palsy in an elderly, always have giant cell arthritis in the differentials, because we also have GCA as one of the causes, and it can present with an isolated sixth nerve. And GCA need not only present with arthritic AIOL. That's one more point. And other thing is, like in India, at least what we see in our clinical practice, more than 60 to 70% of our patients are with vasculopathic risk factors. So that need not only be your take on for making a diagnosis of vasculopathic risk factor as a cause for the sick or cranial nerve palsy, but coming to sixth nerve, the chances of you asking for an ESR and CRT along with the blood test will help you in not missing a GCA as a cause in such conditions. And other is pain for sixth nerve. Sometimes you may have patients coming with repeated attacks of pain and diplopia. And when you see something like that, sixth nerve will be the common one which is associated such painful diplopia. Dr. Verna, could you elaborate what would be the workup if you see a patient with recurrent sixth nerve palsy with pain? What do you suggest?
If imaging is done or not?
Negative imaging.
No, so we usually repeat imaging and we do it with contrast and we try to look for localized lesion. So we tell the radiologist where to look for it and what we are thinking of.
Because sometimes we may have some granulomatous inflammatory conditions like IgG4 disease, sarcoid, or any granulomatous spectrum, which may be, it would respond to steroid, but it would recur and the patient can come back. And other factor is an ophthalmoplegic migraine. Any patient with painful diplopia and recurrent, you always keep an ophthalmoplegic migraine also in the differential. So,
thank you, Dr. Ambika. Yeah, Dr. Ambika joined us. Thank you, Dr. Ambika, for joining us. She's the Director of Neuro Ophthalmology at Shankar Nethralaya, Chennai. We move on, Shikha.
Yeah, with that having covered sixth nerve, let's move on to the third nerve palsy. And to give the talk on third nerve palsy, we have Dr. Manjushri Bhate, again from LB Prasad Eye Institute, Hyderabad Neuro Ophthalmology Department. She is a consultant with LBP. Over to you, Dr. Manjushri.
Thank you so much. And can you hear me and see my slides?
Yes, we can.
Good. So I have figured out the slide share. Very good evening to everyone. And at the outset, I'd like to thank AIOS, the ARC committee, Dr. Bhavan Kule and team, and Rashmin, Rohit, Shikha, everyone for including my presentation. So I'm going to take you through what next and about the third nerve. And to begin, let's start with the case. As you can see in this photo, this is a sort of middle-aged patient who's presenting with a ptosis, which is partial as well as a outward deviation of his left eye. So he came with a complaint of horizontal and vertical diplopia. He had also decreased vision in his left eye, drooping of the left eyelid, and this was the presenting visual acuity. And if we look at his presenting illness, he had no history of any ocular trauma, surgery, no symptoms of headache, nausea, vomiting. He was using glasses. He was a hypertensive, which was medically controlled. And this is his 9-gaze photo. As you can see over here, there is limitation of elevation, there's limitation of adduction of the left eye, and there is limitation of depression. Along with that, if we have a close look, his pupil on the left side also appears to be dilated. So in essence, this patient had an incomplete third cranial nerve palsy with a mid-dilated pupil on the left side. His other cranial nerves were intact. So here what I'm trying to draw your attention to is that a pupil involvement is a red flag for a compressive lesion of the third nerve, and very often it may present as an incomplete palsy, and very often pupil may be the first sign following which the ocular motility limitation may come into play. So this patient was advised an urgent MRI, brain in orbit with contrast, and an MR angio. And as you can see over here, he's presented with this aneurysm, which has been marked by the radiologist, 8.8 by 6.6 millimeters, which was compressing on his third nerve and resulting in the partial third cranial nerve palsy. So this is something which is very dangerous. This is something for which I would even need to wake up the radiologist in the middle of the night saying, do this immediately and urgently, because if this aneurysm bursts, then this patient is not going to survive. So this is a life-threatening emergency. So third nerve is, in a sense, one of the really dangerous cranial nerves that we deal with. So a very careful evaluation and appropriate investigations are important. So again, this is the same MRI oblique section showing the aneurysm. So when we come to the third cranial nerve, it can be either partial or complete. And the features I've written on either side, that is incomplete ptosis and varying degree of limitation of adduction, elevation, and depression with or without pupil involvement. Whereas in complete, it is a complete ptosis with complete limitation of motility, again with and without pupil involvement. And this can happen either in the young or an elderly or an old patient. So in a sense, a third nerve palsy is a finding that we are seeing. We are not saying that this is a diagnosis, but we need to look for the etiology, which is going to give us a complete diagnosis of what is going on, or a complete picture of what's going on in our patient. So the take home, I would say, from this case is that it's really important to rule out compressive lesions. Pupil involvement may be the first sign, and a neuroimaging is essential. Let's look at another patient. So this is a patient who again is presenting with an incomplete a ptosis on the right side, and looking at her elevation, depression, and limitation of adduction, there is variable limitation of extraocular movements in the right eye. So in a sense, we're looking at another case of incomplete third cranial nerve palsy. In this case, the pupils were not involved, but she still had on neuroimaging, she still had a very large meningioma sitting there. So any incomplete third cranial nerve palsy, regardless of whether there is pupil involvement or not, does warrant neuroimaging. So I just want to drive this really clearly, that incomplete cranial nerves, we don't just do a prothrombotic profile or don't just do the blood test, but also take that extra step to find out what is going on with the neuroimaging. Sorry, I know what's okay. So on the other hand, this is, so as we discussed about recurrence and pain in the previous sixth nerve palsy presentation. So this was a patient who came with horizontal diplopia. He came with this recurrent pain, which was sort of, troublesome. He had a history of dengue fever previously, and then he noticed this droopy eyelid, and he had the classical telltale signs which were suggestive of a partial third cranial nerve palsy on the left side. He also had an anisocoria. And here, as you can see in this neuroimaging, this third cranial nerve is so beautifully lit up over here like a Christmas tree. So you can see the entire course. So this patient had something like an oculomotor neuritis. And this was following the dengue fever. So this was a post-infectious sort of inflammatory pathology. But in these cases, it's very important to do all thorough investigations, including the ACE, ANCA, and any sort of inflammatory markers to find out why this particular, sorry, I know what's going on. So why this particular, the way it's presenting. So again, as you can see, both in the axial as well as in the sagittal sections, this entire course of the third nerve is very well lit up over here. He was treated with a course of oral steroids, and this resolved completely. So again, another case of incomplete third cranial nerve where neuroimaging was essential to come to a diagnosis. So looking at the way patients or adult population present with varying etiologies of third nerve, commonly in the 5th to the 8th or 9th decade, of course, this is Western literature, but we are seeing microvascular component to be quite remarkably involved. So ischemic third nerve is very common and more seen in the elderly age group. So doing a complete metabolic workup is, and controlling these risk factors is really important, equally important, I would say, in such cases. So moving on, so this third cranial nerve is a nerve which kind of, starts from the midbrain, goes here, goes there. So, and then finally reaches the eye and the muscles. So if we look at different sections of it, first we have the nuclear part, which has the nuclei in the midbrain. It has the oculomotor nuclei and the Edinger-Westphal nuclei as components, which can be both unpaired and paired, which we would have learned, way back in our anatomy days. But what's important to remember that is if it's a nuclear involvement, it's usually a unilateral palsy with a bilateral superior rectus and a LPS involvement, which is common. Then is the fascicular part of the third nerve. So this is where that third nerve is sort of moving around in the midbrain, and it is crossing the medial longitudinal fasciculus, the superior cerebellar peduncles, then it goes and traverses between the red nucleus, and then it exits out of the midbrain. It's like a little car roaming around on different paths. So what's important in a third nerve, fascicular part of the third nerve involvement, is that there would be other neurological features. So there would be here is where we get all these syndromes, the Claudes, the Webers, the Benedicts. So there will be some more neurological involvement other than just the third nerve. So for example, if there is a red nucleus, there is contralateral ataxia. So I'm just not going to go into every fine minutiae of that, but it's important to try and localize or look at these extraocular features as well, to try and find out where exactly is the possible site of lesion. Then we come to the subarachnoid part. So this is between the superior cerebellar peduncle and the posterior cerebral arteries. And here is when it's going to then pierce the dura and then enter into the cavernous sinus. So commonly these have the compressive lesions or the aneurysms, which would be a causative factor for a third nerve palsy. Then coming to the cavernous sinus. So here we have this ophthalmoplasias where it would not be an isolated third nerve. It could be some more nerves involved, like the trigeminal or the abducent nerve. And then is the orbital part. That is where it is entering into the orbit through the superior orbital fissure. And in these cases, it's important to also see whether there is any optic nerve involvement or not. So this is just kind of a snapshot of what all that third nerve does till it reaches our muscles and where all it can be involved along its course. So this is again just giving a little pictorial representation of the origin, the course. This is more the origin, which is showing the cranial nerve nuclei, and a little bit of the location of the pupillary fibers, which are located towards the outside or not in the central core, where a ischemic or microvascular third nerve, commonly in diabetics, would cause. So here there is the compression which would affect the pupillary fibers because they're sitting on the outer side. So I'm just going to break the third nerve. This is nothing to do with third nerve. This is just a little scene scenarios just to give us a different view. And let's move on to, so in the approach, we need to look at the approach towards the etiology. So go through the surgical sieve of, is this an infective, inflammatory, traumatic, compressive, ischemic, or a neoplastic cause? Approach to localizing where is the lesion involved. Then approach to investigating your particular patient. So doing a blood workup, doing a neuroimaging, as we have discussed previously, which imaging to order, when to request, when to prioritize is important, especially in cases which are life-threatening, sight-threatening, and then approach to management, that is either non-surgical or surgical. So investigations, we need to again tailor-make as per the patient. So blood investigations mainly to rule out ischemia, inflammation, or infection as per our case. Radiological investigations, so what to order would be an MRI, brain and orbit with contrast, I've not written that, with an MR angio or a CT angio. Especially a CT angio would pick up even smallest size of aneurysms, but whatever either of those two, based on what we feel is our case, that is elderly complete, I wouldn't really go on to order all this, but an incomplete, young or old, especially with pupil involvement, yes, definitely on priority. And also investigations which would rule out other differential diagnosis wherein it doesn't clearly, give us this kind of picture, or there is some variability, and then we want to rule out things like myasthenia or thyroid, or even think of something like an internuclear ophthalmoplasia in such other differentials. So non-surgical management, that is mainly prism, monocular occlusion, of course, prisms. Botox, I really haven't tried much in third now, but it is an option. And then a surgical management, which again follows some general principles of observing initially, then clearly explaining the goals of the surgery, doing a staged procedure, and then depending on what is the degree of the muscle involved, what exactly can be offered to the patient. So this is often challenging, the surgical management, and there are limitations because a lot of the eye muscles are not really functioning. So options are, I would say, kind of better if it is incomplete and there is some medial rectus function and we can resect or plicate. If there is some amount of hypertropia, even supraplace those muscles. Sometimes we need to go to the other eye to try and match the defect. And in case of complete, there is a whole gamut of things that we can do because there's no one procedure which is the best or it can work. But essentially, it is mainly tackling the muscles that are working. So either a supramaximal recession or a periosteal fixation, or splitting that lateral rectus, bringing it nasally to the medial rectus. Additionally, working on the superior oblique muscle to try and transpose it. And then again, there is always another eye. So looking at the other eye and trying to convince the patient that if he still wants better cosmesis, to go in for other eye surgery. So in these cases, it's really important to have adequate counseling of these patients and have realistic expectations from what is being offered to them. So let's look at one last case. So this girl had a
Manju, so you might have to conclude.
Conclude. Okay, sure. So basically, this was just a surgically managed case, which was a congenital third nerve. She had a supralarge exotropia and she needed a split of the lateral rectus and transposed to the medial, and she had a reasonably good outcome. So these are my take-home pearls. That is, the third nerve is not just a diagnosis, it's a finding. So we need to hunt for the etiologies, rule out mimickers. Neuroimaging in specific indications is very important. An incomplete third nerve palsy is often dangerous, so we need to find out the cause and treat it. Non-surgical management is equally crucial, and surgery has its limitations, so we need appropriate counseling. So thank you very much for your patient listening. Thank you.
Thank you so much, Dr. Manju. That was a very extensive but very nicely covered, very important topic of a third nerve palsy. May I now ask the panelists as to what is that threshold for somebody who is 60 plus, has a third nerve palsy, complete third nerve palsy, pupil is not involved. What is the threshold for neuroimaging? Would they jump and go ahead and do the neuroimaging, these patients, or rely on the clinical findings? Jaspreet, Jyoti, any panelist?
Yeah, basically, if it's like that 60-year-old with vasculopathic risk factors and pupil is not involved, probably I would wait. Definitely for about 2 weeks. And then
complete also.
Yeah, complete third nerve without pupil involvement. Yeah. So because the pupil rule comes only if it's complete. Then incomplete, there is no pupil rule. You have to image whatever it is. So I would definitely wait for a couple of days and get basically the glycemic status under control, because that would be probably the most common reason. And then go ahead after that, the other investigation what I would order. So it will definitely be not jumping first, but waiting.
Yeah, so basically watch them over time and see, but never lose the follow-up, call them, because if something is evolving, we need to follow. One other thing I just want to say that we are looking at cranial nerve. So it's simple for the general ophthalmologist. Sixth nerve, you're looking at a horizontal diplopia with no pupil involvement, no ptosis. We're looking at the third nerve, we are looking at a horizontal and vertical diplopia. There could or could not be ptosis, and there could be pupillary involvement with or without. And if you're looking at a fourth nerve, you're looking purely for a vertical deviation with no pupil involvement, no ptosis. So this is what you should look at when you are evaluating. And the other thing is, when you are looking at a third nerve, if you find a pupil involvement, it is a mandatory emergency, because if the patient has an aneurysm and if it bursts, it can be fatal. But if it is not, as we said, depending on the risk factors, we can follow up. And then, but always keep a close monitor, because if the pupil involvement, no pupil involvement can become pupil involvement after 21 days. So you need to gradually watch and see if that can happen or not. So keep on follow up. That's it.
Thank you.
Yeah, Rashmin, one thing I want to add here regarding management part, she has covered excellently, Manju. But the conservative part, no. So every case, I think probably should be taken as part of the non-surgical treatment for botulinum injection. The lateral rectus muscle should be given the botulinum injection. We should give under microscopic control, probably making a buttonhole opening at the tenuous insertion point, and we can try with botulinum injection. At least 1 or 2 injections if we give, we can prevent the that nasty contractures going to develop around the lateral rectus muscle, and in future, in due course, it may recover complete or incomplete, but the recovery process is definitely enhanced with that, and it will be helpful in the future surgical management. That I want to add.
I think one important question is what type of imaging is required, because the general ophthalmologist would like to know whether you want to do a CT scan or an MRI in these cases. So, what is the imaging modality?
So only an MRI brain in orbit with contrast. And again, as we are saying about compressive lesions, with an MR angio or with a CT angio, either MR angio or CT angio. One of the two is very essential. Only an MRI is going to miss an aneurysm.
Yeah, I think the CT angio picks up even the smallest of
Smaller
aneurysms.
size, yes.
Yeah.
More
So probably
smaller
a
than MRIs.
CT may be helpful in those cases initially, then a CT angio, and if that's negative, probably go in for an MRI.
I generally tend to order an MRI with MR angio. We get a good package discount as well. But an MRI and then a CT or an MR angio, either of the two. But an MRI is initially definitely required. I mean, I wouldn't replace an MRI with a CT if that's what the question is.
No. In case any doubtful MRI reporting, or if the aneurysm is not seen, but still we have a suspicion, in that case we can go for conventional CT angiography and digital subtraction angiography. Probably that will pick up even small lesions, small aneurysms.
Thank you all. So since these were the talks on cranial nerve palsy, let's conclude and say that it is important both for the sixth nerve and third nerve for your threshold to image or to investigate further should be low, because as was highlighted, these two can be the first manifestation of very serious underlying neurological problem, which can be potentially fatal. Number one. Number two, please remember all these rules apply of observation only if it's an isolated mononeuropathy. So it's very important that clinically we look at the other nerves. For example, in the sixth nerve, very carefully look for corneal sensation and the sensation on the face, because sometimes the only other nerve which can be involved would be the fifth nerve. Similarly, in the case of third nerve, also look at very carefully the involvement of the fourth nerve, because sometimes the lesion of the cavernous sinus orbit can have a third and a fourth nerve combined. So make sure that the clinical examination, at least of involvement of the other nerve, is done in the case of sixth nerve and third nerve. And as was highlighted, that nowadays the threshold for neuroimaging is coming down rapidly, because sometimes the underlying cause can be quite devastating. And so it is a balance between missing out a devastating cause versus a clinical judgment. So I think that's the take-home message. Since there was a lot of talk on Pupil, let's go ahead and have a next talk on Pupil by Dr. Madhvi Bijlani. Dr. Madhvi is joining us from Mumbai. She was trained at Michigan by Dr. Sangeeta Khanna and Dr. Trope. Dr. Madhvi, are you ready?
Yeah, I'll just share my screen, sir.
Yeah.
Should I start?
Sure. You can go full screen.
Yeah, just a second.
Yeah.
Okay, so a very good evening to everyone, and a big thank you to Dr. Rashmin, Dr. Bavankule, and AIOS for having me here today. So I'll be talking about the importance of pupillary examination. So we all know that, just a second. Yeah, so the pupils, we all know, constrict in response to light and dilate in response to darkness, but they're not only a window to the eyes, but a window into the mind. They respond differently to fight or flight or the sympathetic parasympathetic response. They respond differently to neurodegenerative disorders such as Alzheimer's, to drugs, as well as emotions. So I'll be covering today's talk under 5 headings: the anatomy, reflexes, and anisocoria. So anatomically, we know the pupil is a single aperture in the iris, slightly nasal and inferior. In certain pathologies, it may be D-shaped, as in trauma or colobomas, and if it may be in different positions, and the color usually is determined by the pupillary reflex. And we move on to the first light reflex. That is when a beam of light is shown into the eye, the pupil constricts. We all know this. But usually we tend to just look at the direct light reflex or the pupil of the eye in which the light is shown. It's important to see the indirect light reflex as well. That is constriction of the pupil of the other eye where there is no direct light stimulation. So why does this really happen? I'm just going to jump into the anatomy a little bit. So after the afferent pathway, that is the light goes from the optic nerve chiasm tract to the pretectal nucleus, there is a double decussation of the fibers into the Edinger-Westphal nucleus. And from here, the efferent pathway starts, and eventually through the oculomotor nucleus and the nerves, there is constriction of both the pupils. So even if you shine light into one eye, both the pupils are going to constrict. Let's see how we demonstrate this. So usually this is done in a dark environment, because if you keep the lights on, physiologically the pupils will constrict. The patient is asked to focus at a distant object, because focusing at a near object will induce the near reflex. We use a bright torch light and shine it laterally to medially and observe constriction of the pupil. This is repeated 2 to 3 times on either side. Here I'm demonstrating the direct light reflex. For consensual, I tend to separate both the eyes by using my palm in between so as not to directly stimulate the other eye. So I'm shining light on the right eye and observing the left pupil, and now the other way around to demonstrate the consensual light reflex. So since I've mentioned the near reflex now, let's see what that is. It has 2 components, convergence and accommodation. So it's basically a triad of increased accommodation, convergence of the visual axis, and constriction of the pupils. How do we demonstrate it? So when a patient is focusing at a distant object and you shift the focus from far to a near object, the eyes converge medially. Along with this, there is increased convexity of the lens. Of course, this cannot be demonstrated by us clinically, but you can demonstrate constriction of the pupils or meiosis and medial rotation of the eyeball, which completes the triad of near reflex. So let me just quickly discuss a case. This was a 46-year-old female who presented with severe headaches in 10 days associated with some blackouts. She's hypertensive since 5 years and taking regular treatment. On examination, her anterior segment, vision, color vision, everything was okay. But her right pupil was fixed at 4 mm. It was not reacting to light, but reacting to near reflex. We dilated and saw her fundus, and she had this disc edema in both her eyes, which really puzzled us. I questioned myself whether I had missed out an RAPD in the right eye. Could this really be optic neuritis, but her vision and color vision, everything is fine? Or could it be IIH, which the profile she fits into more? So we went ahead and did an MRI, which showed a transverse sinus stenosis suggestive of an IIH. And at her next follow-up, what I did was used 0.125% pilocarpine, and her pupil constricted, showing that she had an AD stonic pupil, or like we call it Hickham's dictum, true and unrelated, 2 different problems which we confused as one. So coming to light near dissociation, what is this? The pupil responds better to a near reflex than to a light reflex. This could be seen in some types of optic neuropathy, AD stonic pupil, Argyll-Robertson pupils, dorsal midbrain syndrome, and aberrant regeneration of the third nerve. ADs, like I discussed in the previous case, has female predilection, presents with difficulty in near work, or sometimes is incidental, as in our patient, mostly idiopathic, but may be associated with lesion in the ciliary ganglion or short ciliary nerves. The pupil is dilated with poor or absent light reaction and slow constriction to a near effort. There may be some segmental iris palsy. So important to remember that a normal pupil will not constrict with such dilution of pilocarpine, but a supersensitive pupil in this case will constrict. Argyll-Robertson pupils again do not show any reaction to light, like you can see in the video. But when you show a near stimulus, there is brisk pupillary constriction to this near stimulus. This may be associated with some systemic conditions such as alcoholism, multiple sclerosis, etc. And these patients need to be investigated. Next is dorsal midbrain syndrome, which encompasses a lot of things, including light near dissociation, upgaze palsy, nystagmus, lid retraction, downgaze in primary position, and skew deviation. So after these, we move to some abnormal pupillary phenomena, beginning with afferent pupillary defect, which has already been discussed briefly, light near dissociation, traumatic pupils, pharmacological pupils, and Horner's syndrome. So what is RAPD? Like Sir discussed, it's a defect along the afferent pathway, including the retina, optic nerve, chiasm, and tract. So there's a paradoxical response of pupil. So instead of the pupil constricting to light, it dilates. But this is seen only when there is an asymmetry of the optic nerve involvement. There will never be there is no concept of bilateral RAPD or Marcus gun pupil. So like demonstrated in the video earlier, the patient is asked to look at a distant object and a bright flashlight is shown to the pupil. Reaction is noted. Similarly on the other eye. And then this swinging to and fro is repeated several times. Do not swing the beam side to side around a very close central axis because this can stimulate the near response. And observe the pupillary response each time. If there's dilatation in any of the pupils, that shows a positive relative afferent pupillary defect. It's important to differentiate this from hippus, which is actually nothing but a sort of a fluctuation in size of the pupil seen in some young patients. And this can make the diagnosis of RAPD a little difficult. So in these cases, please observe the other pupil as well, because hippus could be bilateral and correlated with other signs such as the optic nerve findings, vision, color vision, etc. so as not to confuse and misdiagnose this as RAPD. Now, what do we do when one pupil is not reacting in case of synechiae, a traumatic mydriasis, or a third nerve palsy, as you can see in the left pupil here? So there's a concept called reverse APD, where we tend to observe the one pupil that is actually reacting to light. So this is a normal pupillary response. But if the patient has an optic nerve involvement as well, in addition to the pupillary involvement, which is a positive reverse RAPD. When we shine light onto the reacting pupil, it will constrict. But when we shine it on the other one, where the optic nerve is involved, the other reacting pupil will also dilate, which demonstrates a reverse APD and shows us that the left-sided optic nerve may also be involved. Very, very important to note. Opacities of the ocular media, especially dense cataracts, vitreous hemorrhages, will never cause an RAPD. However, a very extensive retinal damage could cause RAPD. Marcus gun phenomenon requires asymmetry, like I mentioned earlier, and hence will never ever be bilateral. RAPD will never coexist with anisocoria in a unilateral pathology. So either the patient has anisocoria or RAPD because the consensual light reflex will maintain the pupillary size. So another case, this was a 24-year-old female who came with diminution of vision in her left eye since 2 days with some sort of a dull pain. She has history of sinusitis, everything else is okay. On examination, her left eye vision was 624, everything else seems fine. But the only problem was this patient came to me dilated because the optometrist had already seen her before me and dilated her and not documented the pupils. So when I saw her fundus, there was this sort of nasal stuffiness around on the nasal side of the disc of the left eye. So was this really optic neuritis? I wasn't sure. The patient was anxious, fitting the profile of a sort of optic neuritis patient. So we went ahead and did an MRI, which turned out to be normal. A battery of tests was done in their hospital, a VP, ERG, everything normal. And when she came to us the next time, the pupils were absolutely normal and reacting briskly to light. And eventually, the patient was diagnosed as posterior scleritis. So just a simple pupillary examination before you dilate the patient can help you to distinguish a very dangerous pathology. So the causes of RAPD are endless. Anything that can hit the optic nerve can cause RAPD. I'm not going to go into the theoretical details of all this, but an RAPD should signify an optic nerve involvement. Coming to the last part of my lecture, anisocoria, which is difference in the size of both the pupils. So this is a complicated chart that we've been seeing since our postgraduate days, where there's anisocoria in the dark versus the light, and a number of different eye drops are used to diagnose the type. But I feel clinically it's a little difficult to have all this available to us, especially apraclonidine, cocaine, and we can't really use it practically. So I've come up with this other sort of a distinguished table. So if the patient has anisocoria, irrespective of more or dark in light, you check if the pupils are reacting. If either pupil is not reacting, these could be your differentials. It could be a tonic pupil, like the AD's case, where you check for a light near dissociation. It could be a third cranial nerve palsy, where there'll be other signs and the pupil will constrict with 1% pilocarpine. It could be traumatic when you check on the slit lamp and you'll see sphincter tears. Pharmacological dilated pupil will not respond to any sort of pilocarpine concentration, or dorsal midbrain syndrome. However, if the pupils are reacting, but there is anisocoria, you have two diagnoses, Horner's syndrome or a physiological pupil. Apraclonidine, if it's available, you could test and reverse the Horner's syndrome with it. But if not, you can clinically judge because Horner's syndrome will be associated with other findings such as upper lid ptosis, upside down ptosis, apparent enophthalmos, anhidrosis, etc. Also, depending on the degree of involvement or where the lesion is, there'll be systemic signs with the Horner's syndrome. First order or brainstem spinal cord lesions will show you certain dysthesias or paresthesias. Second order lesions or Pancoast tumors, there'll be chest involvement or certain respiratory tract symptoms. And third order lesions will be more localized, includes causes like cavernous sinus, CCF, etc. So I'm leaving you with this complex chart again. And this is an easy way to diagnose these things, but it's easier if we have the differentials in our mind, and then we can go ahead and decide which requires urgent help and which doesn't. Thank you so much.
Very nice talk, Madhavi. It was very interesting with so many animations and all.
Thank you, ma'am.
So with that, I invite comments on the talk from Dr. Mahesh, Dr. Jaspreet, Dr. Jyoti.
Madhavi, that was a wonderful talk, and as she beautifully demonstrated. So only one point I would like to add that in case of ADS people, denervation supersensitivity sometimes may not occur in the acute stage of the pure occurrence of the ADS pupil. Denervation may develop 1 or 2 weeks to develop. So in that stage, if we look for a hypersensitivity, we may not be able to detect it. But of course, there are other features which Dr. Madhavi has told, like tonic contraction to near and other responses are seen. That's all I would like to add.
Horner syndrome is. Anybody else wants to add? Otherwise,
Horner's.
Painful Horner's syndrome. In pupils, I think a painful Horner's syndrome is one of the medical emergencies, you know. If somebody is doing pupillary evaluation carefully, you can save a life or, you know, you can prevent a stroke. It can be a very subtle finding. Patient may come with just, you know, little vague symptoms of some irritation, pain around the face. And then you see that, you notice that the pupil is a little smaller, and then you do your test for the anisocoria increasing in darkness, and then you look at the pupil and you find there's a subtle ptosis too, and you know, connect everything, and then with that with these findings, basing your diagnosis of painful Horner, you need to send the patient for detailed investigations, which includes MRA, MRI, head, neck, chest. So either basically for the general ophthalmologist, if you know your pupils and if you know that this could be the thing, don't hesitate. You could prevent a stroke, you know. Otherwise, yeah, you need to refer to a neuro ophthalmologist. So this is one condition in pupils where, you know, ADs is a very benign condition, but Horner's, especially acute painful Horner's, could lead to devastating conditions.
Especially after injuries, I mean bike accidents in young patients, young people, and then especially after the history of surgery, undergoing oral surgery, some procedures, and neck injuries. So they are coming with that mild ptosis and then this meiosis. So we need to suspect Horner syndrome. So those cases, this carotid dissections following injuries. So those cases, really it is a life-saving measure we are going to. If we identify Horner syndrome and do take proper steps with neuroimaging and other things. So general ophthalmologists, they need to know to refer to the neuro-ophthalmologist in those findings.
That's it. Any other comments? Otherwise, we'll move to the next talk and to to give the next talk, I invite Dr. Vidya Dharni from Shankar Netralaya. She is a consultant in the Neuro Ophthalmology department. And Dr. Vidya will be telling us about the role of OCT, optical coherence tomography, whether it's important in Neuro Ophthalmology diagnosis. Over to you, Vidya.
Thank you, ma'am. Well, my topic is whether OCT is useful in neuro-ophthalmology. To start with the basics, we know OCT is a non-invasive, a quick and a reproducible imaging technology. It studies the various layers of the retina and the cross-section of the optic nerve head. Areas of interest in neuro-ophthalmology is, apart from the optic nerve head, includes a peripapillary retinal nerve fiber layer, the ganglion cell layer, along with the inner plexiform layer, which forms a ganglion cell complex. With the enhanced depth imaging, we can visualize structures up to the level of lamina tuberosa. OCT allows a qualitative and a quantitative assessment of optic nerve disease. There are different types of OCT, mainly the time domain, the spectral domain, and the step source. The spectral domain and the step source are used more frequently or commonly because of higher level of resolution. So what are the parameters of OCT of interest in neuro-ophthalmology? It includes the RNFL thickness and the GCC complex. The average RNFL thickness is around 105 microns, while that of the GCC is around 90 microns. The normative data for people less than 18 years is not available. We should remember this. With the RNFL thickness, we can quantify the axonal loss, but the neural damage can be assessed by assessing the level of the ganglion cell complex. The pattern of ganglion cell complex always correlate to degree and pattern of visual field loss. So the entities of interest in OCT for neuro-ophthalmology, it includes the optic nerve head drusen's. OCT can detect buried drusen's. So what advantage it has over ultrasound, which is still date considered gold standard for detecting a drusen? Well, OCT detects non-calcified drusen's. It differentiates from PHOMS. It gives information regarding neuroaxonal integrity. It also has a prognostic value with regard to the optic neuropathy associated with optic disc drusen's. So here is the image which shows multiple drusen's, and these drusen's are identified as hyporeflective core with a hyperreflective margin. The next entity is these peripapillary hyperreflective ovoid mass-like structures. The first thing we must know are these are non-specific markers of axoplasmic stasis in the optic nerve head. They can be associated with any disc edema, disc drusen's, and an anomalous disc. Here this image shows a hyperreflective ovoid structure with no definitive margin. So where can we apply OCT in neuro-ophthalmology? The most clinical application is in papilledema, where an accurate and objective monitoring of the degree of optic disc swelling can be done by assessing the RNFL thickness. It also quantifies the resultant optic neuropathy by assessing the GCC thickness. Reduction of optic disc swelling and RNFL thickness with preservation of the ganglion cell complex indicates a good response to treatment, while reduction in both the entities indicates worsening of optic neuropathy, treatment failure, or fulminant IIH. So this is a fundus photograph of a young female who presented to us within 1 week of onset of symptoms of raised ICP. As we see, she has gross disc edema. Correlatingly, her RNFL thickness is extremely elevated. It is around within 600 to 700 micrometers. Her GCC is all thinned out at onset. So this patient had fulminant IIH. She did not respond very well to treatment. The next condition is to differentiate between true papilledema and pseudo disc edema. There is always a diagnostic dilemma in differentiating patients with buried disc drusen's, a crowded disc without drusen, and an early papilledema, especially if the patient is a child, where we have to avoid unnecessary painful interventions. Figure A shows a small crowded disc, but the OCT shows a normal RNFL thickness. The second figure again is a small crowded disc, but OCT has beautifully picked up the drusen's, and there is changes in the RNFL thickness. The third picture is of a patient who presented with signs and symptoms of raised ICT, but she had an early disc edema according to Prenzel's grading, and that can be seen with the RNFL thickness, which is marginally elevated. The other clinical application of OCT is in optic neuritis. If the patient has a frank disc edema, we see the RNFL is thickened, but atrophy usually sets in by 3 months. We must know that in multiple sclerosis, the temporal quadrant is most frequently involved. while the vertical quadrants are involved in NMO-associated optic neuritis. To your right, we can see the MRI image of a young girl, again, who presented with right optic neuritis with MS. At 1 month follow-up post-treatment, her RNFL level was still normal, but GCC showed a borderline thinning in the right eye, involving the temporal quadrant predominantly. Again, in optic neuritis, the ganglion cell complex is a sensitive measure of retrobulbar neuroaxonal injury. Its thinning occurs much earlier than that of RNFL thinning. RNFL loss indicates or correlates with defective optic nerve functions. But the ganglion cell loss correlates not just with the optic nerve dysfunction, but also with the quality of life measures, disability, and MRI findings. The other important application is seen in compressive optic neuropathy. Any lesion, any space-occupying lesion along the visual pathway causes thinning of these RNFL and GCC due to retrograde degeneration. And these changes are seen much prior to the disc pallor on the fundoscopic examination or defects on perimetry. It has a predictive role, that is, it can assess the visual outcomes after decompressive surgery. If the GCC count is less than 50 microns prior surgery, the visual outcome is usually poor. OCT has a very significant role in monitoring and management decisions in pediatric optic pathway gliomas, who are generally managed in a conservative conservative way. And this OCT can tell the visual loss, especially in non-verbal children. Here we see a classical image of an pituitary adenoma with bitemporal hemianopia. There's borderline thinning of the RNF in the right eye and fairly good in the left, but the GCC shows nasal thinning bilaterally corresponding to the temporal visual field loss. The next application is in neurodegenerative diseases such as Alzheimer's and Parkinson's, where it is a useful biomarker. The upper and the lower quadrants are involved predominantly. The amount of thinning of these parameters correlates with disease severity. Progressive loss indicates a disease progression. OCTA is more sensitive as it can also assess the retinal hypoperfusion, which is an assumed pathology in these neurodegenerative conditions. So here is the OCT picture of a 75-year-old male who was diagnosed with atypical Parkinson's disease a month ago. His visual acuity and fundus was normal, but we see that he already has thinning of RNFL as well as a GCC complex. So here are a few cases where OCT helped me in my clinic. First is a 40-year-old female who presented transient visual blurring in the left eye since 2 months. Her visual acuity and anterior fundus examination was normal. The right eye fundus was normal. The left eye disc showed an early edema with no obvious obscuration of vessels. Ultrasound was negative for drusen. But on OCT, we show this asymmetric increase in the RNFL in the left eye, which is also seen on the EDI OCT. With this, I suspected her to have asymmetric papilledema, which was confirmed with the LP showing increased CS opening pressure. The next case is of a 21-year-old female, an engineering student, who presented with sudden drop in vision in the right eye since 11 days, associated with headache. Her visual acuity was normal. She did have RAPD in the right eye, but fundus shows evident or superficial drusens bilaterally. To my surprise, she had visual field defects bilaterally, the right eye being involved more. So considering her age and presentation, I suspected her to have optic neuritis, of course atypical, but again neuroimaging and serology for atypical workup was normal. So optic neuritis was unlikely in this patient. So what was the cause of vision loss in her? We had a closer look at the OCT. We can see she had bilaterally multiple drusens. Her RNFL thickness was marginally elevated in the right eye. Left eye was normal, but GCC had a different story to tell. It was thinned out temporarily in both the eyes, corresponding to the nasal visual defects bilaterally. So this patient had compressive optic neuropathy secondary to optic disc drusens. Next is a 12-year-old male who presented with signs and symptoms of raised ICT. He had abduction limitation and fundus we see there is disc edema bilaterally. He had a mild EBS. MRI was suggestive of raised ICT2. RNFL showed an increased thickness of around 300 range bilaterally, and the GCC was fairly okay. But this case is a case of pediatric IIH. At 1 month follow-up with treatment, we see the disc edema has resolved, and RNFL also, OCT also confirmed the significant reduction in the RNFL thickness, and the GCC was maintained. So this case highlights the use of OCT in children, even though there is no normative data. My last case is of a 19-year-old female who presented with sudden painful loss of vision in the right eye since 6 months. Her vision was recorded as no PL. The other parameters were normal, but disc also appeared fairly normal. But VEP showed marked delay in latency, and pattern VEP was undetectable waveform. This was a bit confusing. MRI, which was done elsewhere, was reported as normal. We still suspected her to have a functional loss, and this suspicion was confirmed with the OCT parameters being normal. So we did refer her to the psychiatrist and the psychologist where she was diagnosed with conversion syndrome. So in spite of all these uses, OCT still has its limitations. Whenever any longitudinal study is planned, the same machine must be used as different machines have different protocols. Anatomical variations must to be considered. Like if a person with a myopic disc can have a thinning of the RNFL on OCT. Optic media opacity such as cataracts and corneal opacities can alter the image quality and reliability. And this test depends a lot on patient cooperation and fixation. So to conclude, OCT is a non-invasive, quick imaging modality to study the neurosensory structures in the eye. It plays a significant role in diagnosing, monitoring, and has a prognostic value in certain neuroophthalmic disorders. It has a great potential for research, especially neurodegenerative disorders. To conclude, yes, OCT is useful in neuroophthalmology. And my last slide is we welcome you all for the annual conference of INOS. It is scheduled to be in September. The registration and after submission link is already open. Kindly visit the official website of INOS. Thank you.
Thank you, Vidya. Thank you. So whenever we speak about OCT, the first name that comes to our mind as a panelist who can discuss about it is Dr. Shikha Basi, who is my co-moderator. The reason being she has extensively published about OCT neuroophthalmology and has spoken about it in various national and international fora. So Shikha, fortunate to have you here to give your expert comment and to have more light, to throw more light on the subject. Shikha.
Thank you, sir. Thank you for this kind introduction. So OCT, very nice talk, Vidya, especially the cases that you showed at the end. Very complete presentation of the cases, and the cases did show the role of OCT in neuro-ophthalmology for the neuro-ophthalmologist. But we'll try to understand the OCT's role for a general ophthalmologist. I think for a general ophthalmologist, OCT can play a huge role in differentiating between an optic neuropathy and a maculopathy. Most of the general ophthalmologists today have OCT machines, and they do image the macula. The same can be done for the optic disc, and anything happening at the optic disc will be enhanced by a look at the RNFL, peripapillary RNFL. Little thinning, little increased asymmetry between the two discs will give you an idea whether the disc is, there is some pathology, some axonal stasis occurring there. And macula, most of the general ophthalmologists are, subtle ERM or things happening. Combining OCT with multifocal ERG will 100% clinch the diagnosis of differentiating between subtle maculopathy like azure, differentiating it from retrobulbar optic neuritis. Another thing that at this point I would like to say is that for a general ophthalmologist, the OCT can be used in teleophthalmology in co-managing the case. If, for example, I have quite a few patients of IIH who come here to Shankar Nethralaya, or they come to the institutes, and after that the follow-up is done by the local ophthalmologist, and they just send me the OCT images of the patient, and then we tell, this is the treatment to be stopped, tapered and all. So there's a huge potential of OCT in co-managing the cases with the Neuro Ophthalmology at the tertiary eye care center. Same thing can be said for the recurrent optic neuritis. This is happening right now with few of us managing the patients like this with the local general ophthalmologist. So there is a potential of combining teleophthalmology with OCT. I think with that, we'll move on to the next talk. So
thank you so much, Shikha. Thank you for those wonderful words. So in conclusion, OCT has a role to play in neuro-ophthalmology for prognosis, for follow-up, and maybe at some point in time we might even use it for diagnosis, hopefully once we have more data about what's going on. So let's move on. It's a pleasure to invite Dr. Rebecca. Rebecca is from RPC. So we have now two approaches which the patients that we see in our comprehensive ophthalmology clinic. So Rebecca is going to talk about approach to a patient with diplopia. Over to you, Rebecca, and thank you for joining us.
Thank you, sir. So I think diplopia is a pretty common complaint that we see in neuro-ophthalmology. And but remember that whenever a case of diplopia walks into your clinic, important thing, first and foremost, is that you must rule out whether it's a monocular or a binocular diplopia, because these two entities have entirely different causes and entirely different management. And how can you do that? It's quite simple. You just cover one eye of the patient. And if the diplopia persists, it is a monocular diplopia. So monocular diplopia is essentially associated with more of a local condition like corneal issues, retinal issues, pupillary issues. However, if it does not, if the diplopia does not alleviate on covering one eye, then that means it's a binocular diplopia. And it is this binocular diplopia that I would be discussing today. So basically, binocular diplopia, where the patient is seeing two physiological images for one physical image, and it's essentially caused by the misalignment of the two eyes. So this differentiation of monocular and binocular becomes the first step for general ophthalmologists, because we see a lot of wrong referrals happening to neuro-ophthalmology clinic. Now, binocular diplopia is actually a worrisome condition because it's associated with several life-threatening neurological conditions. So causes could be neurogenic, which may range from supranuclear, nuclear, internuclear or infranuclear disorders, or it could be myogenic causes, which is your nerve muscle junction disorders like myasthenia, or muscular issues like inflammation or some other trauma to the muscle. But essentially, the major chunk of binocular diplopia is caused by the paralytic strabismus, and most of this has been covered very well by Dr. Virna and Dr. Manjushri. So whenever so what do you do in the workup of binocular diplopia? So it is important that you take a relevant history. So the onset, progression, it's important. Whether there is intermittency in the symptoms. So that you can relate it to myasthenia. Any exacerbating or relieving factors, past medical history, especially vascular risk factors like diabetes or hypertension. Then assess what type of diplopia patient complains of, whether it's horizontal, vertical, torsional, or a combination of these. Whether the diplopia is becoming worse for distance or for near. Like there is a worsening of diplopia for distance, horizontal diplopia, most likely it could be a fixed nerve paresis. Then look for associated symptoms like neurological signs of headache or proptosis or loss of vision. In the orthoptic workup, it's important that as the patient first walks into your clinic, you observe the head posture, because that is the time the patient is least conscious, and you get an idea about whether the patient has some incompetence in the incompetence, because that leads to a head posture. Then check the extraocular movements. So remember, for general ophthalmologist, always start with the primary position. Here you observe whether the patient has any deviations, then go on to the secondary gazes. That's the dextroversion, levoversion, elevation and depression, and then on to the tertiary gazes. So that way, nicely, you will get the idea whether there is what type of strabismus, in which gaze the patient is having the limitation, and whether the deviation is increasing in any particular gaze. Then it is hairs and leash charting that you should do if you have the access to it. Diplopia charting using red and green glasses. So diplopia charting will give you an idea what type of diplopia, whether crossed, uncrossed, and whether the diplopia is increasing in any particular gaze. if there is involvement of cyclovertical muscles. That means if the patient is having a vertical misalignment, like in this case, patient has a left hypertropia. So you must do a Parkes 3-step test to identify that which of these cyclovertical muscles are involved. So this patient has a left hypertropia that is increasing in the right gaze and on left head tilt. So if you actually do the calculation, it's very mathematical. So if you do the calculations, you will come on to the conclusion that there is an involvement of the left superior oblique muscle. So similarly, there could be involvement of other cyclovertical muscles, which you can rule out by the simple 3-step test. So once you have made your diagnosis, then you need to identify what's the underlying cause. So for that, you need to do laboratory investigations and imaging. Yes, what type of imaging? Well, a lot has been discussed already, but remember the imaging of choice mostly in cases of diplopia would be a contrast enhanced MRI of the brain along with or without the orbits. If it's a case of a trauma, we can do a non-contrast CT. If you're suspecting aneurysms, like in painful third nerve palsies, do our MR angiography or a CT angio. If venous sinus thrombosis, then MR venogram would also be needed. Lumbar puncture may be indicated in certain specific conditions, like when you're suspecting meningitis or maybe raised intracranial pressures. So eventually the management would trickle on to the management of the underlying cause or referral of the patient for the same. Meanwhile, how do you manage the diplopia? You give patching, prisms, or botulinum toxin and keep the patient under close follow-up. Now, coming to some of these disorders, so starting with the supranuclear disorders. So here's a video. So this is a middle-aged man. So I just show you the right gaze seems to be normal, but as soon as the patient moves on to the left gaze, what you see is a limitation of adduction in the right eye, and there is abduction nystagmus. And have a look at the convergence. The convergence seems to be normal. So this is a very classical case of internuclear ophthalmoplegia. And so where do you expect the lesion to be? That is the medial longitudinal fasciculus. Now, since you know the diagnosis, you know the possible site of the location based on your etiology, you will direct your imaging towards that. So MLF, you direct your imaging towards the brainstem. And in this case, we found a pontine infarct in the patient. Then just brushing the anatomy, as you can see, the horizontal gaze center is your pontine paramedian reticular formation. So it is lying over here in the pons. So from here, the impulses are traveling to the 6th nerve, ipsilateral 6th nerve nucleus that supplies your ipsilateral lateral rectus muscle, and it supplies the contralateral medial rectus muscle via the MLF. So MLF is a very interesting structure that is going all the way from pons to the midbrain and supplying the 3rd nerve. So if there is an involvement of the MLF, it would lead to internuclear ophthalmoplegia. Then coming to the nuclear and infranuclear disorders. So your major chunk of diplopia are associated with your nuclear or infranuclear disorders. That is your 3rd, 4th, and 6th nerve palsy, which has been well covered already. So I will not go into the details, but remember that anatomy of all these nerves is very important. They all have been divided into particular categories. I mean, the portions of the nuclear, the fascicular part, the subarachnoid space. And because every, based on the anatomy, each of these segments have they can help you identify or localize the lesion. So remember, if there's a nuclear or fascicular involvement, any kind of a 3rd, 4th, or 6th nerve, usually nuclear and fascicular involvement will not be isolated. You will have some neurological signs. So look for those neurological signs like hemiparesis or tremor. Subarachnoid space, usually isolated involvement. And so this is one example. A young male patient presents to us with a sudden onset right 3rd nerve palsy. So you see there's a drooping, there is a limitation of adduction, up gaze, as well as down gaze. And patient also has history of seizures. So you get one neurological feature here along with the acute onset 3rd nerve palsy. So you would suspect something in the midbrain, that is the nuclear part, or in the fascicles. So we did the neuroimaging directed towards the brainstem. And yes, we found the answer. It was a multiple rim enhancing lesions in the brain. And one of them was involving the midbrain that caused the 3rd nerve palsy. It was most likely a case of neurocysticercosis. Then 3rd nerve could be associated with aneurysm. So remember that if it's a painful 3rd nerve, you must do MR angiography and CT angiographies. And pupillary involvement in third nerve palsy, it is a red flag sign. Do in those cases definitely get a neuroimaging done because it's suggestive of a compressive lesion. An example, as you can see, the patient has a complete third nerve palsy. Now here, what you see that there is also a pupillary involvement. So we get a neuroimaging, and of course, we found a intracranial space occupying lesion. If there is a cavernous involvement, then the involvement is not isolated. You will have involvement of other cranial nerves like the fourth, fifth, sixth involvement, as well as third. If there is orbital involvement, you will have orbital features like proptosis or vision loss or chemosis. So look for these subtle clinical features that will help you localize the site of the lesion. So this is one example. A patient presents to us with a third nerve palsy. There's a right-sided involvement. But what you also observe is that there is a mild proptosis, there is mild subconch hemorrhage, ecchymosis. So here you are suspecting something in the orbits or somewhere nearby. So we did our imaging directed towards the orbit and sinuses, and this is what we found. It was a case of sino-orbital mucormycosis. So that's how you direct your imaging and identify the cause and accordingly treat it. Aberrant regenerations in third nerve palsy is another indication for doing neuroimaging that could be, related to, that could be caused by a slowly growing tumor and sometimes also seen in traumatic cases. Fourth nerve, well, it is the most common nerve that is affected by trauma because the peculiar feature that you see in the fourth nerve, that is completely crossing over to the other side. And that is the reason why that bilateral fourth nerve palsies may not be uncommon in trauma. So how do you assess? Here, the patient will complain of a vertical as well as a torsional diplopia. While if there's a skew deviation, which is a supranuclear disorder, the patient might just have more of a vertical diplopia. So in such cases, you must assess the torsion. It could be done objectively by using a Maddox rod or by objectively using a fundus photography. But remember, if the torsion is more than 7 or 8 degrees, you must suspect a bilateral involvement, especially in cases of trauma. Here's an example. A female patient presents to us with a trauma. She has a torsional diplopia. What we observe is that she has a V pattern ESO and an alternating hypertropia in the either gaze. So this was a case of a bilateral superior oblique palsy, although there was an asymmetric involvement. So because of this asymmetric involvement, there are chances that you can miss out one eye involvement or the one eye superior oblique palsy. Then sixth nerve, again, already has been discussed properly. I'll not go into the details. Just remember, because of the a very tortuous course that it's having in the subarachnoid space, raised intracranial pressure can cause the compression and the sixth nerve palsy. So that's a false localizing sign. And that's why fundus examination becomes very important in these cases. So young male patient presents to us with a bilateral sixth nerve involvement. But look at other complaints. He also has a headache and blurring of vision. We checked the fundus. There is a bilateral disc edema. And we did the neuroimaging. So what we found that this was a case of a idiopathic intracranial hypertension, as was evident by the radiological features and CSF manometry. So do not forget fundus examination, especially in sixth nerve palsies. Then another example. Now this case, as you can see, not a very good picture here. I've not elevated the lid, but there is a complete limitation of movement in all the gazes. And there's also a chemosis. So this kind of an involvement where you're suspecting third, fourth, as well as sixth involvement. So this could be related to a cavernous sinus involvement because cavernous sinus is the part where all these nerves are coming together. And if this is associated with a decrease in vision, then probably it's the orbital apex involvement that's causing, so in this case, we suspected something at the cavernous or the orbital apex. So we directed our imaging towards this particular area. And this is what we found. It was a huge trigeminal schwannoma that explained the symptoms in the patient. Then the other causes of double vision, binocular diplopia could be myoneural junction disorders. Well, here again, have a look at the video. So what you see that the patient has a little exotropia, but just keep observing the lid of the patient. So gradually you see the progressive drooping of the lid of the patient. So there is a progressive drooping, so variability in the signs, and there is also with the fatigue, there is increase in the symptoms. So this is So IcePack test was done, and we see a marked improvement following the IcePack test in the drooping of the lid. So this is a case of myasthenia. Now, myasthenia gravis is a very, it's a very good mimicker. It's called to be the greatest mimicker, because if you don't, and the dictum actually goes this way, that you're not able to understand a particular strabismus, then probably, and if it's not fitting into a particular palsy, then it's probably myasthenia gravis. So keeping that in mind, you must be aware of the lid signs. And how can you confirm the diagnosis? By doing a neostigmin test, IcePack test in ptosis patients can be done, prepitative nerve stimulation test, or single fiber electromyography for the orbicularis muscle. Then another orbital cause could be a very common cause, in fact, I would say. As you can see, this patient, he's very prominent eye, so proptosis is quite prominent. There is mild limitation of movements in almost all gazes. And when we did the imaging, so here you're suspecting something in the orbits, a proptosis along with the limitation of movement. So look at the CT. Here the orbital imaging shows that there is a muscle thickening with tendon sparing. So this is a case of thyroid eye disease. So accordingly, then you can manage your patients or refer the patient to endocrinology for the same. And the last example, the patient again presents as a limitation of movement in both adduction and abduction. But what you also notice is the swelling of the lid and a little chemosis. So here again, you would suspect that something is there in the orbit. So
Rebecca, you will have to conclude.
Yes,
we
yes.
are running short of time.
Yeah. So basically, to summarize this, remember that binocular diplopia may be related to supranuclear, infranuclear, or muscular disorders. So very important is to identify those subtle clinical signs that give you an idea as to where could be the possible site of the disease, and accordingly tailor your investigations and imaging towards that. So just do remember the anatomy. Thank you.
Yeah, very, very nice presentation, very comprehensive. So with that, I'll ask Dr. Jasprit Sukhija to give his comments.
Yeah, no doubt. I mean, she's covered just everything, nothing left for me to comment. For the general ophthalmologist, I'll just give one, you can say, a little nice, you can say, a nice clue to diplopia. So patients who come with monocular diplopia, I mean, no doubt they'll present with diplopia. You see it's monocular. Just try doing a pinhole test. The moment if the diplopia goes away with a pinhole test, you know you have some refractive error you're dealing with. So that is one important thing in your OPD which you can do. The other thing is binocular diplopia. Diplopia charting is one important thing. You can know what is a cross diplopia or an uncrossed diplopia if things are not evident when the patient has an ESO or an exotropia. The third thing what you see in the clinic is many times they undergo cataract surgery and they start complaining of diplopia. So one is monocular, but the other thing is a decompensated superior oblique palsy. In your young age, you are usually controlled. Even maybe you have a esophageal, but it's controlled. The moment any kind of surgery you undergo where the accommodation goes away, it starts to manifest. So these are some of the things what you would see in your clinics, and probably may not require much of investigations. But yes, a thorough workup is required. You can say an OPD, ocular workup is required in these cases.
Thanks, Dr. Jasprit. So with that, I invite my colleague, Dr. Durga Priyadarshini, to tell us, she's from Shankar Netralaya, senior consultant with us at Netralaya. Dr. Durga will be talking about acquired ptosis, neuro ophthalmic approach. She'll be telling us about the acquired ptosis workup. Over to you, Durga.
Thank you, ma'am. At the outset, I'd like to thank the ARC and Dr. Rashman sir for giving me this opportunity. So my topic for today is acquired ptosis, and let's see how we approach it neuro-ophthalmically. And a few of my slides might be a repetition of the previous speakers, but let's take it as a revision, and so let's not miss any of these conditions. So to start with, ptosis can be congenital or acquired, and acquired ptosis can be classified based on the etiology like mechanical, traumatic, aponeurotic, neurogenic, or myogenic. So a little bit of recap of anatomy. Elevation of the upper eyelid is done by the contraction of the levator palpebrae superioris and the superior tarsal muscle or the molars muscle. The levator palpebrae superioris gets its nerve supply from the superior division of the third nerve, and the molars muscle gets the supply from the sympathetic plexus from the superior cervical ganglion. So to start with, how to identify and acquire ptosis. It starts with a detailed history taking and a complete clinical examination. So when you look into the history taking, always probe for sudden onset. Always probe for the onset of the ptosis, as a sudden onset may signify a underlying serious problem, and look for any associated double vision or diurnal variation or a fluctuating symptom which can indicate an underlying myasthenia, and history of any systemic or neurological associated symptoms should be looked in for, like dizziness or weakness in the proximal extremities, or shortness of breath or dysphagia, and also look for underlying vasculopathic risk factors and autoimmune condition like thyroid eye disease. Never forget to probe for treatment history, including ocular surgery and medical treatment. And never forget about the fat scanning, that is a family album tomogram, so that we get an idea when the ptosis actually occurred for the patient. Moving on to the examination, apart from the proper lid examination, which includes measurement of the margin reflex distance 1 and the palpebral fissure height and the LPS function, one should do a complete pupil examination, ocular movement assessment, adnexa evaluation, and facial sensation. So let's move on to the types of acquired ptosis. Aponeurotic ptosis is the first type, which I would like to say. It is caused by stretching or dehiscence of the aponeurosis and is commonly associated with aging or trauma. So young male who had a traumatic aponeurotic ptosis, you see there's a higher, the upper lid crease is at a higher level and the LPS function is usually preserved. And mechanical ptosis is caused by excess weight on the upper lid. And here is a child with a mass lesion in the supratemporal quadrant. And you also see that the orbit has a dystopia. Traumatic ptosis can be caused by either trauma to the retractor muscle, aponeurosis, or the neural inputs. Moving on to the neurogenic ptosis, it can have a range of presentation depending on the underlying etiology, and the important one is the Honor syndrome, and where the lesion could be anywhere along the sympathetic pathway, and they present with unilateral mild upper lid and the lower lid ptosis or the reverse ptosis, and the pupil can be miotic. The anisocoria is more noted in the dark because of the dilator problem, and facial anhidrosis can be noted, and there are various pharmacological tests for diagnosing and localizing, though they are not practically useful in clinics. The third nerve palsy patient presents with ptosis, the eye could be down and out because of the muscular paralysis, and if parasympathetic fibers are involved, the pupil could be dilated. So one can remember that honors and third nerve palsy involving the pupil could be ruled out if the patient has a normal ocular motility and a normal pupillary examination. Moving on to the next important conditions, the myogenic ptosis. The first important cause is a myasthenia gravis, where ptosis can be early symptom of this autoimmune condition, and they can usually present with unilateral or bilateral ptosis, could be symmetric or asymmetric, and may be associated with ophthalmoplegia. And don't forget that they could be a great mimicker of any cranial nerve palsy. And they usually tend to worsen with fatigue, and positive response can be noted to rest test or the eyes test. And the diagnosis is based on the seromarkers or tensilon test, positive response to the tensilon test, and a repetitive nerve stimulation test could show a decremental response, or a single fiber EMG highly specific test could be done to diagnose in difficult cases if we have the expertise to perform the test. And always remember to do a CT chest in these patients to rule out thymoma. Another important condition or cause for myogenic ptosis is CPEO, where the patient can present to you with symmetric ptosis and can be accompanied by extraocular muscle weakness, but though they rarely present to you with a diplopia. And they also have a reduced saccadic velocity. And never ever forget to rule out a pseudotosis when a patient comes to you with an acquired ptosis. And the causes could be dermatochalasis or asymmetry in the sides of the globe, or if there is a contralateral retraction in cases of thyroid eye disease, one can appear to have a ptotic eye in the other eye. So let me share few interesting cases. My first case is about a 65-year-old female who came with a complaint of left eye drooping for 5 days. And she was a diabetic and her recent HbA1c was raised. So this is her vision was 6.6 and 6 and fundus showed a mild NPDR changes, and it's a 9-gaze photograph which showed a left eye severe ptosis, and she had an adduction limitation, elevation and depression was limited in the left eye. The right eye movements were all full. Pupil examination was equal and reacting to light in both the eyes. So it was a case of pupil sparing third nerve palsy, probably secondary to ischemia, and the plan was just to control the glycemia, just to control the diabetes and to keep her under a close observation. So the next case is almost very similar. 56-year-old female came with a left eye drooping, but the duration was 2 years. She also gave a history of diminution of vision for past 2 to 3 years, and she also told that her past MRI brain and orbit, which was done elsewhere, was normal. Vision in the right eye was 6.6 and left eye was 6.18, and she had a corresponding cataract in the left eye. Color vision was intact, fundus was normal, and the field which was relatively okay. And this is her 9-gaze picture. She had a moderate ptosis in the left eye. There's a mild adduction limitation and elevation limitation was noted. Depression was also limited. I'd like to show the pupils here. And she had a left eye pupil, which was dilated and sluggishly reacting to light. And on a down gaze, she had a lid lag. So it was a case of left eye pupil involving third nerve palsy with aberrant signs. And yes, unless proven otherwise, I would not be carried away with the normal MRI in the past. I wanted her to repeat the MRI to rule out any compressive lesion. And this patient showed a flow-wide signal at the posterior cavernous region, which was confirmed by doing an MR angiogram, which showed a PCOM aneurysm at the origin of the PCOM. So the next case was a 55-year-old male. He came with the complaints of right eye drooping of the lids for the past 6 months. He also gave history of associated binocular vision and a vague history of blurring of vision in both the eyes. Otherwise, systemic history was unremarkable. Vision in the right eye was 6.18 and the left eye was 6.9. Color vision was intact, though he had a slow response. Otherwise, the fundus examination was normal. And this is the extraocular motility. He had a right eye moderate ptosis. Abduction was intact. Elevation was limited. Adduction was completely limited. Depression was fairly okay in both the eyes, and he did not have any lid lag as the previous patient, but the pupil in the right eye was slightly enlarged and it was sluggishly reacting to light. So it was a case of chronic right partial third nerve palsy involving the pupil. I advised him to undergo a visual field test, which showed a right eye temporal heminopia, and the left eye was constricted with a more denser towards the temporal side. So an MRI brain and orbit picked up a cellular mass with a paracellular extension and a chiasmal compression, secondary to a pituitary adenoma, and he was referred to the neurosurgeon for further treatment. The next case is about a traumatic ptosis in a 10-year-old boy who came with a trauma 2 weeks back. But let me tell you what are the red flag signs in this child. He had no PL in the right eye, and extraocular motility had a completely frozen globe in the right side. And the sensation, the V1 and V2 segment were also involved. So it was a case of multiple cranial nerve palsy involving the second, third, fourth, fifth, and the sixth nerve. So it is lesion probably localizes to the orbital apex up to the cavernous sinus because the fifth nerve were also involved. An MRI brain and orbit with contrast was done. It showed a lesion, soft tissue lesion from the apex till the cavernous sinus, and this section shows a hypointense linear lesion at the posterior cavernous sinus SOF region, and it was a suspected wooden foreign body post-traumatic penetrating injury, and he was referred urgently to the neurosurgeon for further treatment. This is my last case where a young female came with a complaints of right eye mild drooping of the lids for the past 1 to 2 months. Otherwise, her vision was 6.6, pupils were round and reacting to light equal in both the eyes. Ocular motility showed a mild elevation limitation. Otherwise, the fundus examination was normal. And this is the external picture of the patient. And if you look at this keenly, there is a mild ptosis in the right eye, and she also has a mild lower lid retraction in the right eye, and there was an obvious lateral flare in both the eyes. So we suspected probably she's having a thyroid orbitopathy. But why will a patient with thyroid orbitopathy present to us with the droopy lids? So patient was advised, we did a ice pack test and it was very classically positive. So it was a case of probable myasthenia gravis associated with thyroid eye disease. Yes, it's a very known entity to have myasthenia and thyroid in the same patient because of the autoimmune pathology. And she was advised neuroimaging and further blood tests, including thyroid and zero markers for myasthenia, and started on treatment by the neurologist. So I'd like to summarize that the diagnostic triad in neurogenic ptosis involves along with the ptosis, one needs to assess the extraocular motility in the pupil. Third nerve palsy patients can have unilateral ptosis and extraocular motility limitation, and pupil could be normal to dilated, and if dilated, the anisocoria is more in bright light. And on a syndrome, patient can have a mild ptosis and a reverse ptosis, extraocular motility usually normal, but if they are involved, they could localize to the cavernous sinus region, and the pupils are miotic and anisocoria is more in dark. Myasthenia gravis usually presents with a variable ptosis and a variable extraocular motility disturbances, and pupils are never involved. And I'd like to add a note that unilateral ptosis with elevator palsy or bilateral ptosis with extraocular motility limitation, always remember to rule out any midbrain lesion. So my take-home message is accurately identifying ptosis and its underlying etiology is important for a successful management, and review the patient's history to understand the timing and the timing of the onset and associated symptoms. And in all cases of ptosis, one needs to do a careful pupil and ocular movement assessment, and it is important that we never miss a third nerve honors or a myasthenia, as the consequences can be very grave. So, and plan your treatment based on the etiology. Thank you so much. And I would like to re-invite you all for the INOS this year at Shankar Netralia. And we have very popular and star speakers this time. And see you all there in Chennai. Thank you.
Thank you. Thank you, Dr. Durga. Invite comments from our expert panel. Any comments, suggestion?
Yeah, I'd like to say, for the general ophthalmologist, it is very important to know whether it's a pseudotosis or a true ptosis. So in that condition, you always ask the patient to fix with the lid with the ptosis, and when the patient is fixing, if the lid moves up, probably we're dealing with a pseudotosis, and which is usually found in patients with double elevator palsy or a monocular elevation deficiency. So that part should also be kept in mind. Otherwise, it's a very comprehensive talk and well covered, and when to do imaging. It was, of course, giving the guidelines what you should see when you're having a patient with ptosis.
Dr. Raman?
Yeah, one more thing I want to add here is the pupillary involvement is extremely important. To look at the pupillary response, and in myasthenia, it never involves the pupils. So that really helps us to rule out myasthenia straight away, and you can avoid unnecessary neuroimaging. And other thing is we should always look for the light near dissociation, and especially bilateral ptosis. Suppose if it is presenting with then we should look for along with pupillary response and size and all, and the light near dissociation also we should look for. Suppose if light near dissociation is present, then strongly we need to suspect the midbrain ptosis and then the midbrain space occupying lesions. But anyway, wonderful cases you have presented, beautiful cases. Thank you so much.
Jyoti?
One more point I wanted to add is, especially if you see an acquired ptosis in a child, it's very important that you need to watch that the child doesn't develop amblyopia. So I had this case who had a bilateral third nerve palsy, and we investigated thoroughly. It came to me after investigation completely, and we finally realized that this patient had myasthenia. And what was needed is just an empirical treatment, which is given with pyridostigmine and steroids, and that showed that there was an improvement. But in that course, we ensured that the patching was introduced so that child doesn't get amblyopic. We had one more case of acquired third nerve where we had an inflammatory response, and suddenly the patient developed an acquired third nerve. Again, there it's important that you start patching, because even a few weeks of closure of the eye because of ptosis, the child can get significantly amblyopic, and then trying to get back vision can be a disaster. So in children, always remember that if the eye is closed, covers the pupillary visual axis, it's important that we introduce amblyopia treatment like patching.
Thank you. Thank you so much, all our experts. So basically, the take-home message is that any acquired ptosis, our antenna should be up, because it can be a muscle problem, a nerve problem, or a myasthenia. Myasthenia is a great mimicker. There have been instances where acquired ptosis was operated upon, myasthenia was missed, and patient ended up with lid lag, exposure, and also a funny ocular motility, and he blamed everything on a ptosis surgery. So it's extremely important, when in doubt in acquired ptosis, postpone the surgery, observe patient for a month or two if you're not very sure what is causing the acquired ptosis. So to conclude, it's important to make sure that all acquired ptosis has a proper diagnosis before any surgical intervention is planned, if at all. Now that we come to the last part of this, and as there has been a tradition with these ARC webinars, they call it saransh. So that means a conclusion of the entire all the subjects that we covered, and also some of the recent papers that a speaker would like to discuss. And it's an honor to have Dr. Swati Fuljule. Dr. Swati is a professor at RPC, and she's also a joint secretary of Indian Neuro Ophthalmology Society. Thank you, Swati, for agreeing to do saransh, and over to you.
Yeah, thank you, Dr. Rashmin. I think the Saramsh is the one which was started by Dr. Prashant, is to just give the gist of what are the recent trends which is being followed. Because many of the general ophthalmologists might not have time, or they might not, for the journal clubs. So just giving them a gist of what's going on in the journal so that they can get the take-home message and they can implement in their clinical practice was the motive behind this Saransh. So I once again welcome Dr. Swati Madam for this Saransh, and this all will be relayed. I think this all will be put up in the YouTube channel of ARC. So I request all the delegates who are there, Mr. Sunil from AIOS will be putting it up in the YouTube of ARC YouTube channel. I request you to all subscribe for it, and then you can find the entire webinar of today's under the ARC YouTube channel as well. So over to Dr. Swati Madam. Thank you very much for accepting to be a part of this Saransh.
Thank you, Dr. Rashmi, and thank you, Dr. Bavankile, for giving me this opportunity. Yeah, so I just, reframed it as neuro-ophthalmology update. There are many articles, there are many, multiple articles depending on the disease, the optic neuropathies, and on the oculomotor issues that are being generated every year. But I chose these two particular topics because one, optic neuritis is the most commonly encountered condition for general ophthalmologists as well as neuro-ophthalmologists. And IH, because it's the incidence is increasing and there are a lot of doubts, there are a lot of issues now coming up because the incidence of IH increasing. So for that reason, I've chosen these two topics and would limit the update to these two topics for this particular talk. And I'll try to keep it very concise and simple to make it a very simple thing for general ophthalmologists to understand what is going on in the field of optic neuritis and IH. So my first talk is about this. My first article is about this wonderful manuscript that is published in Lancet in 2022. This is a kind of consensus article where multiple of neuro-ophthalmologists, neurologists, ophthalmologists have come together to find a consensus about the diagnosis and classification of optic neuritis. Due to the advent of multiple antibodies, the clinical picture of optic neuritis has changed over time from what it was there during the period of ONTT till date. So they have tried to give a diagnostic criteria for optic neuritis, where they have divided the criteria into three parts: the clinical criteria, the paraclinical criteria, and how these two things can be used to understand or to give a definite diagnosis of optic neuritis. So for clinical criteria, they have monocular, subacute loss of functions, and the most important thing, RAPT. So it's a case of typical optic neuritis. So as you can see that the A is typical optic neuritis, B is all the features of A, but there is absence of pain. So this A is a typical optic neuritis, but B is what we call as atypical optic neuritis, and so is C, where they will have all the features of A and B, but the vision loss is binocular. So classically, the A will be a typical optic neuritis, which is an MS-related optic neuritis, while B and C will be classified as an atypical optic neuritis, which have other etiologies, which we will be seeing during the course of this presentation. The paraclinical criteria includes OCT, role of OCT, role of MRI, and role of serology biomarkers. So we have now OCT has been discussed by Dr. Vidya that, it is quite commonly used for the follow-up of the patients in neuro-ophthalmology, particularly optic neuritis and IH. So it has to be taken into account whenever we are dealing with the case of optic neuritis. The diagnostic value of MRI and the diagnostic value of biomarker is important because, whenever you have optic neuritis, the MRI, it becomes very, very important. What MRI protocol and how it should be done is also discussed in the subsequent slides. Similarly, for biomarkers, we are now commonly doing aquaporin 4 associated antibodies, which is a biomarker for NMO disease, and MOG antibodies, which is a biomarker for MOG associated optic neuritis. So taking into these account these two criteria, the definitive optic neuritis, when there is a typical optic neuritis and one of the paraclinical tests is positive, it is a definite optic neuritis. While if you have B and C conditions, you need to have two paraclinical tests positive and one of them has to be MRI. So for definite optic neuritis, you have these three possibilities. For possible optic neuritis, when you're not sure whether this is optic neuritis or not an optic neuritis, you can consider multiple things like paraclinical, depending on the clinical situation, fundus examination. If the history is consistent with the typical finding, maybe you can consider it as a possible optic neuritis. What I'm trying to emphasize here that in spite of all these tests and everything, the clinical examination is still the most important part of diagnosing optic neuritis, particularly presence of visual dysfunction, color contrast, and presence of RAPT. So moving from there, they tried to then classify optic neuritis into multiple levels. The level 1 includes whether it's an infectious optic neuritis and optic neuritis related to systemic diseases. So there's a long list of systemic diseases, including autoimmune conditions, vasculitis, sarcoidosis. Those conditions can present as optic neuritis, and long list of infections, bacterial, viral, parasitic, which can lead to infectious optic neuritis. The more important of concern here is autoimmune optic neuritis, which is associated aquaporin 4 antibodies, CRMP5 antibodies, and MOG associated antibodies. They are further classified as depending on the clinical course as MS-related optic neuritis, single isolated optic neuritis, recurrent optic neuritis, or chronic recurrent isolated optic neuritis. So as and when we see a patient of optic neuritis, we need to, kind of put them into certain brackets so that we can tailor investigations accordingly. Otherwise, there's a huge list of investigation that we may need to do in cases of optic neuritis, and there's quite some debate about the fact that how much should you investigate in optic neuritis, which is a different matter altogether, and probably panelists can discuss this after this presentation. So here you have the classification of optic neuritis. Then they try to understand the role of MRI, and it's much more important for general ophthalmologists to understand that MRI is the choice of investigation for the optic neuritis, and it's not just writing an MRI is enough. The MRI has to be MRI brain with orbit. That's the most important thing. The strength signal should be at least 1.5 Tesla or greater than that, and it should be focused at the orbit and as well as the desired brain area. It should be a contrast MRI associated with fat suppression on T2 sequences as well as fluid attenuation to highlight the hyperintense lesions and contrast enhancement of the optic nerve. They also try to understand whether the localization of hyperintensity or the localization of lesion on MRI can help us to differentiate the various types of optic neuritis or various etiological causes of optic neuritis, and found that if the optic nerve enhancing and optic nerve enhancement is associated with retroocular orbital fat enhancement, as well as if there is a longitudinal enhancement of optic nerve sheath there, it is suggestive of perineuritis. It is probably more associated with MOG. Subsequently, a long enhancement of optic nerve involving up to the chiasma or maybe proceeding beyond that is suggestive of NMO. A typical MS lesion is an isolated optic neuritis, isolated hyperintense lesion, and does not involve the entire course of the optic nerve. For serum antibody, it was recommended that at least these 3 antibodies should be regularly examined for aquaporin 4 antibodies, MOG antibodies, and collapsing response mediator protein 5 antibodies. Unfortunately, we still do not have CRMP5 antibodies available in India, but we do have aquaporin 4 and MOG antibodies now getting more and more available at all places. What we need to note that it's the cell-based analysis which is much more important than the simple ELISA test for these optic neuritis, which will give you more specific and sensitive results for the presence of antibodies. So depending upon the clinical course, they further try to, classify optic neuritis. So depending on the cause of the optic neuritis, it could be acute demyelinating encephalomyelitis associated optic neuritis, which is a bilaterally simultaneous optic neuritis, generally occurring in childhood, but not exclusively limited to childhood. It is generally seen post-vaccination or post-infection. Then the other two are now well-defined identity, the aquaporin 4 antibody associated optic neuritis. And it's important to note that this optic neuritis is kind of form for NMO spectrum disease. So another commonly seen antibody is MOG antibody and associated optic neuritis, which can present in multiple ways. Optic neuritis is just one of the presentation. MOG can also present as AGEA. MOG can also present as other like cerebellar signs. So you have to keep all these things in mind whenever we are dealing with a case of optic neuritis. A classical MS-related optic neuritis is generally an isolated optic neuritis, and the chances of these optic neuritis patients developing a fully blown MS depends on the number of lesions, the number of brain lesions that are found in MRI, as was suggested by ONTT. Depending on the clinical course, they now try to classify the optic neuritis as a single isolated event for which we don't know the cause, or maybe the antibodies are negative or not yet discovered. So a single isolated event which patient develops and may have good recovery post that. Mostly it can be labeled as idiopathic optic neuritis. The second type of clinical course can be a relapsing isolated optic neuritis, where the optic neuritis relapses irrespective of the steroid dependency, and the antibodies are still negative. So we don't know what is the cause for the relapse, but it will relapse whether the steroids are continued or not continued. The next in the list is chronic inflammatory relapsing optic neuritis, where the relapse occur and it depends on the steroids. So whenever the steroids or the immunosuppressant agents are withdrawn, the relapse is occurring. So this type of optic neuritis is a chronic relapsing optic neuritis, and this even may not show any presence of antibody. Then you may have optic neuritis, which they classified as prelaminar optic neuritis. That means that's not the optic nerve head which is primarily involved. It's the surrounding retina or neuroretinal areas which can be involved and can present as optic neuritis. They also tried to give this new definition, new type of optic neuritis, primary progressive optic neuritis, generally seen with the progressive MS. However, this is primarily a diagnosis of exclusion when you exclude all the other causes of optic neuritis, including the infectious and systemic associated disease, before you label a patient as a primary progressive optic neuritis. So from the classification and the diagnosis, now this paper has given us an idea about what is the evidence-based management of optic neuritis. So there has been a lot of confusion earlier about IV steroids, oral steroids. So this paper has tried to give us that IVMP indeed is the treatment of choice. It does hasten recovery in the cases of MS-related optic neuritis or idiopathic optic neuritis. It is the same conclusion that has been given by ONTT quite decades back. But what we need to understand now, that in case the patient has atypical optic neuritis, by that I mean if the patient has autoimmune antibodies present in serology, or the patient has atypical features, it may not be enough to give IVMP. Then you have to understand whether the patient is having recovery, or there is minimal recovery, or no recovery. So generally it has been seen that MOG-associated optic neuritis has a good prognosis, and many a times it can be managed with IVMP alone. However, it is the optic neuritis with or associated with NMO which needs to be managed more aggressively. And in such cases, IVMP along with plasmapheresis needs to be considered. It has been seen that plasmapheresis, when given early in the disease course, has more likely chance of recovery as compared to when it is given in the late in the disease. Long-term immunosuppressive therapy is needed in patients of NMOSD depending on their poor visual recovery and recurrent attacks. Long-term immunosuppressive therapies may also be needed in cases of MOG-associated optic neuritis, provided it's a recurrent attack. Many a times we may not consider giving immunosuppressing therapy if it's just a first attack. So if it's definitely indicated if the attack is recurrent. So this paper just tried to give us evidence based that how you need to treat an acute management of optic neuritis. The next paper is from India. I particularly chose this patient so that we understand what is the Indian scenario in the current perspective. So it has been quite some time when this paper was presented, published in 2014. When we found that, the Indian scenario, the etiology, the clinical course of the optic neuritis in India is not as that has been described in the Western literature. So at that time, we didn't know what is going wrong with our patients. We didn't know why our patient profile, why their outcomes are different from that has been classically reported in ONTT or other Western literature. So we reported that the poor visual outcomes are seen with our patients, and most of our patients do not have typical clinical manifestations as that has been reported in ONTT. That was the paper that came in 2014, and since then, a lot has changed. And this new paper, somewhere published in 2022 by Dr. Ambika et al., has now given us a better idea of the Indian scenario in optic neuritis. So this paper has tried to look at the serological markers in cases of optic neuritis and had reviewed around 203 optic neuritis patients presenting in between 2018 to 2019. So they found that almost 28 to 30% of patients had MOG antibodies positive, while around 10% of patients had NMO antibodies positive, which is in corroboration with the other paper published from India as compared to Western literatures who have less number of MOG patients and relatively lesser number of NMO patients. So most of our patients are MOG positive. The paper also told us that around 60% of patients will be double negative. So we still don't know what is the etiology for these optic neuritis patients who do not have either of serological markers. Then only 6% of patients were diagnosed as MS, in contrary to the Western literature, where most of the bulk of the optic neuritis patients are MS related. It also told us that, after the multiple logistic recreation, it's also told us that the MOG-associated optic neuritis is found to have better prognosis as compared to the other optic neuritis, particularly MS-related optic neuritis. So after optic neuritis, I would like to now talk about IH. So a lot has changed in IH also. IH was first initially considered a very, very benign disease. But now there has been a lot of change. We have multiple issues in IH, vision loss and associated systemic diseases which are now coming up in IH. So this particular patient has kind of tried to show that how our understanding about the IH disease mechanism has changed over a period of time. So the key points of this paper is now that the IH is now considered as a metabolic disease rather than a benign entity which is limited to CNS. And it has a range of systemic association, if not manifestations. So the key features still include obesity as a major risk factor. It is classically still seen in young female which is in the period of fertility and is obese. But it has also been shown that IH patients have impaired infertility. They have at more risk of gestational diabetes as compared to patients who do not have IH. They have more chances of increased cardiometabolic complication and sometimes even cognitive dysfunctions. So it is not as benign as it was considered. There are multiple comorbidities associated with IIH, like PCOD, like obstructive sleep apnea, like anxiety and depression. So whenever we are we are dealing with a patient of IIH, it's important that we need to look into the history of these particular associated systemic diseases. So do ask about this history, look at the hormonal profile of these patients, look at the other clinical associations of these patients. Anemia is also considered as nowadays as one of the major risk factor for development of IH. So these are the things that are systemic associations for IH. Along with that, it has also been seen that there is a positive relationship between headache and intracranial pressure. So higher the intracranial pressure, more is the severity of headache. So it may be an indirect, a marker to understand that how severe is the headache. Weight loss has been established as the only disease modifying therapy as far as IH is concerned. And it's so much so weight loss is established as the only disease therapy for IH because so that the patients have been advised to undergo bariatric surgeries, and the newer therapeutic avenues are now emerging to target the metabolic pathways to improve the weight loss. Sorry, somehow my animations are not coming into picture.
Swati, you have to make it a full screen.
Yeah,
Then the
I didn't
animation
realize that I have to make it slideshow. Yeah, sorry. Correct. So yeah. So this was an important treatment trial in IH, which assess the role of acetazolamide and weight loss in cases of IH. Although this study is not so new, it was started in 2014 and probably the results were published by 2017. But I'm just trying to give you an overview of what were the outcomes of the study, which were published by Stacy et al. In this Journal of Headache. So basically, idiopathic intracranial hypertension trial randomized patients into two groups where they gave acetazolamide and weight loss in one group and placebo plus weight loss in another group. So these were the key conclusions from the IIH treatment trial study. So they have proven what we have known for ages, that acetazolamide is a treatment of choice for IIH. And what they have also tried to prove that instead of small doses, one may have to step up the dose of acetazolamide over a period of time if the patient is not responding. They have established that it is safe and tolerable to give up to a dose of 4 grams per day, although many a times maybe our patient may not require that kind of dose, but a higher dose of around 2 grams is generally given in our setup. So a dose of 250 milligram twice a day or 250 milligram thrice a day may not be enough for the management of IS patients. The second thing they commented upon OCT, as Dr. Vidya has already spoken about, that OCT has to be used regularly for the monitoring of these patients. Most of the time, it will be sensitive enough to pick up the changes in the RNFL and GCL layer. But one needs to understand that in cases of severe disc edema, because of the segmentation error, the OCT may not reflect the true picture of the RNFL and GCL thickness. They also tried to show that probably GCL is the GCL layer. We need to look into the thickness of the GCL layer to look at the prognosis of IH in these patients. They also tried to understand whether the OCT changes correlate with the clinical picture and correlate with the visual function. But unfortunately, they did not find the significant correlation between the OCT markers and visual function and the clinical picture. They also tried to understand whether the headache severity can be managed by they found that even the visual function than the placebo group, the head was not well controlled in acetazolamide. To make us that weight loss, which is a strategy as far as headache is enough. Something wrong with the animation. So yes, so the importance of weight loss is so much so, as I was talking about that, various come up to understand whether surgery versus the cognitive weight is more important for patients, or it is now a metabolic receptors, which are molecular receptors, which are now gaining importance in the management of weight loss in this patient. So what I'm trying to emphasize here is, just giving acetazolamide may not be enough. And it is important to counsel the patients for weight loss, and weight loss somewhere around 6 to 20% is what has been recommended by various studies in the literature if we want to have earlier and favorable outcome. So this is a current study published from our center to understand the impact of weight reduction on the structural as well as functional parameters of the optic nerve in cases of IH. So we try to correlate the change in the weight, or change in the, more specifically change in BMI, with the change in the structural, by that I mean OCT parameter, and as well as the change in visual function parameters. So we found that the change in BMI was directly in correlation with the change in papilledema. So a greater change of BMI led to a greater change of 4-grade change in the papilledema. So around 7% of weight loss was associated with 4-grade change of clinical grading of papilledema. Similarly, there was reduction in mean deviation and improvement of P100 amplitude if the BMI, which correlated very well with the change in reduction in BMI over a period of 6 months. So this is so similarly, it correlated well with the OCT parameters, where we found that the change in BMI was very well correlating with the change in the optic disc height. So in this particular patient, we tried to grade the severity of IH by measuring the optic disc height on OCT. So we found that the change reduction in BMI correlated very well with the reduction of the optic disc height in these cases of IH. So these were my important updates for optic neuritis and IH. Thank you for your patient listening. But my take-home points for two particular disease is that nowadays we should not, do away with the fact that MRI is not required in optic neuritis. It's an important investigation, a must investigation. At the same time, you have to get serology for aquaporin and MOG antibodies to diagnose a case of optic neuritis. And in cases where you have atypical features like severe disc edema, like absence of pain, and bilaterality, which is not showing improvement, and more aggressive management in terms of plasmapheresis is what is required as far as optic neuritis is concerned. For IH, I would like to say that, the condition is not so benign anymore. We have multiple systemic associations, and therefore sometimes one may have to get hormonal analysis also done in this case. Whenever taking history, please ask for all those associated conditions. As far as management is concerned, step up the dose of acetazolamide and please advocate weight loss for IH. Thank you.
Great talk, Dr. Swati, as
Thank
always.
you. Thank you.
And you discussed excellent papers, very nice discussion, very relevant papers. Any comments from Dr. Mahesh?
Swati, you can stop sharing your screen.
Yeah, sorry.
So it was a great presentation by Dr. Swati, and I have nothing more to add. It has all the relevant latest information. Thank you, Dr. Swati.
Thank you, Dr. Mahesh.
Any comments from any other experts? Any concluding remarks?
No, Varun.
All right. So if there are no further comments, it has been a real pleasure. And I'm sure with all this extensive discussions by all our experts, I'm sure there are a lot of take-home messages that we all have got, which we can implement during our practice, which is one of the main prime objective of the Academic and Research Council of AIOS, that can we have this distilled extract of what we can implement in our practice and improve our outcomes for our patients. We would like to, on behalf of Shikha and all the speakers and moderators and experts, I would like to thank Dr. Prashant and the team ARC for giving us the opportunity. On behalf of Vice President INOS, who is present here, and entire INOS Executive Committee also, we would like to thank for partnering with us. And I hope that this was useful for everybody. Thank you very much and good night.
Thank you. Good night.
Thank you.